Namaste and greetings. I, Samprikta Banerjee, a researcher at IMPRI Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान नई Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the first day of Healthcare and Gender Equity Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges. An online international monsoon school program, a 1 month, a 4-day immersive online certificate training course. This program is organized by the IMPRI Gender Impact Studies Center, GISC. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The distinguished expert panel includes Professor Vibhuti Patel ji, Professor Linda Lane ji, Ms. Jaya Velanker ji, Dr. Padma Bharti Deostali ji, Professor Brunel D'Souza ji, Dr. Amar Jesani ji, Dr. Aksa Sheikh ji, Dr. Veena Vaswani ji, Dr. Anant Bhan ji. The conveners for the program from IMPRI are Mr. Farhad Yenepoya ji, Professor Vibhuti Patel ji, Dr. Veena Vaswani ji, Dr. Manorama Bakshi ji, Dr. Swati Santosh Rani ji, Dr. Simi Mehta ji, and Dr. Arjun Kumar ji. Proceeding further, I heartily welcome you all to this course, Healthcare and Gender Equity Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges. This program will help you all embark on a journey into the intricate relationship between health and gender, a historical tapestry woven with complexities shaping diverse gender perspectives on well-being. The transformative power of gender equality reverberates across health outcomes, fostering benefits for individuals and communities alike. Hence, this upcoming cohort of healthcare and gender equity unfolds as a crucial space for collective exploration, promising deep insights and contributions to the discourse on transformative, inclusive healthcare systems. We sincerely appreciate your valuable time, energy, contributions, and deep enthusiasm for learning and discussing the nuances of healthcare and its relation to gender in detail. Thank you for your active involvement and commitment to learning and progressing. We hope that you take back a plethora of knowledge and valuable information from this course, which shall effectively aid you in your respective fields, along with causing a notable improvement in your skill set. We have also shared the course outline and reading resources via email for your kind reference and perusal. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Without further ado, let us begin with the program. I'm delighted to invite our first speaker of the day, Ms. Jaya Velanker, Director Jagori, for the first session of the day, Engendering Healthcare Systems. Thank you for joining us, ma'am. Over to you.
But before that, Professor Patel, your chair the opening remarks.
Yes. So thank you, Samprikta, for introducing the course. And I would like to now welcome and also congratulate Dr. Veena Vaswani and Dr. Arjun Kumar for putting this course together. We express our heartfelt thanks to Mr. Farhad Yenepoya, Pro-Vice Chancellor of Pro-Chancellor of Yenepoya Deemed to be University. And we welcome our today's guest, Ms. Jayashree Velanker, from the Director of Jagori, and Dr. Amar Jesani, Editor of Indian Journal of Medical Ethics, and Dr. Linda Lane has also joined us today. Now, we are embarking on an existing journey that unfolds an intricate relationship between health and gender, a historical tapestry women with complexities of shaping diverse gender perspectives on healthcare and overall physical and mental well-being. The transformative power of gender equality reverberates across health outcomes, fostering benefits for individuals and households, communities, and nation states. As we navigate the evolving intersection of health and whole gender spectrum, caste, class, ethnicity, religion, geographical location, disability, we shall collectively navigate into the myriad ways in which interplay influences health outcomes, paralleled by policymakers' efforts to ensure responsive healthcare systems. At the same time, ongoing investigations and research inquiries that explore the reciprocal impact on micro, meso, and macro realities that were experienced during the global coronavirus pandemic or SARS in Asia or Ebola virus in the pandemic in African nations states. And they prompt legislators to shape inclusive healthcare frameworks, and series of reforms were introduced in the healthcare policies impacting systems and structures. In this vibrant landscape, health activists, community-based organizations, civil society organizations, feminist organizations like Jaguri, or NGOs, NGOs, and the networks such as People's Health Assembly, PHA, which is active simultaneously at a local, subnational, and national, and regional, and global levels. They tirelessly advocate for inclusive and equitable healthcare, emphasizing a profound understanding of gender as an integral part of health and well-being based on their ground level work of health interventions. Now, this third cohort of healthcare and gender equity unfolds at a crucial space for collective exploration, promising deep insights and deliberations, and sharing of research outcomes and contributions to ensure in direction of intergenerational dialogues between feminist advocates, researchers, health professionals, and policymakers to provide an informed and inspiring space to explore progress in gender equity by making enabling systems and structures that result in health outcomes marked by gender equality. Over the last 4 decades, feminist health movement has brought to the fore important concerns of bodily autonomy, enabling whole gender spectrum to make informed sexual, reproductive, and healthcare decisions. The whole slogan of health rights are human rights, valuing paid and unpaid work of women, and also focusing on occupational health and safety, strengthening health systems to include safe, decent working conditions for majority of health workers. In Indian context, we can call them ASHA workers, and also ANMs, and people of the kind of power relations that are existing within the healthcare system, they have been questioned. Another very important question is that of a sexual harassment at workplace of the health worker, that is also come to the fore. And promoting equitable gender norms, including those that make violence against women and girls, including harmful practices such as forced marriages, early marriages, female genital mutilation, have been taken up by the health movement. Financing universal health coverage and social protection to cover health costs, child care, paid parental leave, and sick and family care leaves, and old age pension have also been debated. Addressing male bias in the development of vaccines, drugs, and diagnostics, and also sexism in the medical and health sciences, and also in the applied sciences have also been debated in the women's movement. Ensuring women's and feminist leadership in the government, health and development agencies, in the UN bodies, and other global organizations has also been a very important agenda, especially after the formation of Gender Equality Forum in the post-pandemic period. Now, with this backdrop, I think we are going to have a very overarching understanding from Ms. Jayashree Velanker in her inaugural address. And over to IMPRI team.
So, shall I start?
Yeah.
Okay. Am I audible?
Yes.
Yeah. Let me first start thanking my dear friend Vibhuti for thinking of me for this topic, and also IMPRI, not only for organizing this summer school, but also inviting me and giving me an opportunity to share some of the concerns which Vibhuti has flagged in her opening remarks. And I congratulate all the participants of this course, and my respects to all the senior people, or so many doctors around. So I feel a little nervous here, or doctors or professors. I'm just an activist with over 40 years of experience in women's health movement. And so I will share basically what we have been fighting for for last so many years. Every few years, there is some hot topic or hot framework that is in the vogue. I will also use that. But we all know that many basic issues have remained the same. And in fact, pandemic has seen worsening of some of those issues and creating new challenges, as it were. And I mean, since yesterday, we have been grappling with the situation in our neighborhood. So, the newer issues will keep coming up and we have to respond to that. So I congratulate IMPRI that you have thought of this special topic. And I will start with the topic or the title of the topic that is given to me, Engendering Health Systems. Now, if you look at the dictionary meaning of engender, it dictionary says it means cause or give rise to a feeling or a situation or condition. But many a times, and last maybe more than a decade or so, or maybe more than that, engender, the word engender is also used for integrating gender concerns, be it in policy, be it in budgets, be it in plans, So I presume that the second usage is in mind of organizers, and I'll proceed to see how do we integrate gender concerns in the health systems. While doing this, I will keep WHO definition of health at the back of my mind, because I still think it is encompassing definition. And if some people are new to that, let me just repeat what is that definition. It's health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So I also have, as Vibhuti has mentioned, I have been an activist, and Jagori, the organization that I'm currently director of, Jagori has been pioneer in the field of women's health. Jagori was the first organization in India to do a feminist critique of mainstream psychiatry. Women and mental health is now, today, it's again a topic in the vogue, but 35 years ago, not many people were talking about it the way we are talking today. So we all come from Health for All vision also. We share that vision. Some of us are founders of People's Health Movement in India, what is called in Indian languages Jan Swasthya Abhiyan. So I have that vision at the back of my mind. And what Health for All implies even today. One, health to be brought within the reach of everyone. I think that still remains. And number two, removal of all obstacles to health. So elimination of malnutrition, poverty, provision of potable, safe drinking water, or elimination of unsafe, unhygienic housing, all today what we call social determinants of health. So that vision, what we had, Health for All by 2000, that dream is yet to be achieved. It remains. So against this, if we see, where do women stand? And I'm talking mainly of cis women from India, which is closer to my lived experiences and also area of work. But we know there are other women on the gender spectrum who also remain equally marginalized in many of the discourses. So though I don't represent them as such, we all share their concerns and we raise our voices in defense of their rights and dignity. So starting from here, if we see, first we have to, and I'm sorry for you senior people may get bored, but I think there are some new students here, and that's why I also want to talk about some basic things, and I would like them to know that patriarchy, as we all know, we talk about patriarchy and how women have been subordinated for centuries, and there is a lot of material available on that. But if we look at the impact of patriarchy, what patriarchy has caused to women all over the world, women in different parts of the world have crossed certain barriers, crossed certain hurdles, won some rights, but overall, the discourse as such has remained powerful across the globe, I would say. And that's why, US presidency has become even more engaging this time. Gender issues have not gone away in any nation state in the globe. So for me, 5 important impacts of patriarchy that we need to keep in mind, whether we are talking about economics, whether we are talking about education, health, family, justice, whatever. The first is denial of rights to property and other resources. We always talk about women's secondary status or subjugation, but what is it? Materially speaking, what is it? It is this. And this is structural violence. I know Dr. Padma Bhatte is going to talk about the other forms of violence that women suffer from and how health system is not responsive to that. But I would like to focus more on the structural violence that women face. The second, I would say, impact is control over productive and reproductive labor. In the earlier phase of women's movement, we used to formulate it this way. Today, we call unpaid care work, right? Reproductive labor is unpaid care work. Third, I would say control over sexuality. Fourth, no role in decision making. And fourth, restrictions over mobility. These are those 5 overarching impacts on women's lives that keep women where they are, and it becomes a doubly difficult struggle for women because they have to struggle against their own family, their own communities, and then other communities and other state and other systems. And health system is no different from other systems. So the structural violence, discrimination, and denial of inequality has rendered women a secondary status. They are constantly at mercy of someone with more power. And this is reflected in state. We all know how the state emerged, state as an institution emerged. So policies and programs of the state and institutions like economy, family, religion, education, whatever you take, they all are replete with this patriarchal ideology and who always consider women to be little inferior subjects who need to be protected, who need to be controlled, who need to be told what to do, what not to do. So we have to look at even health system functioning from this angle. Because once we understand this, then we know that though the MTP law in India does not require parents or husbands or partners' signature, even when adult women approach government facilities for abortion, they are routinely asked for these signatures. And in many cases, women are not able to provide those signatures of their parents or quote unquote their caretakers, as it were. And that's why then they turn away from government services and go to what we call quacks, which are mainly unsafe abortions, which result in lakhs or millions of women dying because of unsafe abortion. So it's one patriarchal understanding which is percolated in our psyche completely, and systems can result in something like this for a woman. And this we need to keep in mind at every juncture, every policy, every facet of life, health that she may, health or health services that she may encounter. Now, it is not, women's movement for last so many years has been struggling, raising voices all over the world. And so we have won small victories. We have now nobody can deny that there is gender inequality in this world, and we need to have some policies, some frameworks which can lead us to a more equitable world order. And these frameworks will help shape our policies and programs. And one such important framework to my mind is universal health coverage. So, and again, that is also in vogue for last at least 2 decades, I would believe. So since we are focusing on health, I'm picking up universal health coverage because there are other such frameworks in other areas of life. So if we look at UHC, and since we want to consider it, if we want to engender health systems, UHC also is important because UHC is based on the principles of rights and entitlements. And that's why I have some hope in that framework, that we need to all pursue that framework and push our governments, our planners, our families, our communities to go into that direction. Now, there are three key dimensions of UHC, as we all know. One is access, where everyone who needs health services should get it, not only those who can pay. Now, is that true for women? We'll see. We'll first list the dimensions and then we will go how women fare. Second is quality of services. That services should be adequate and effective. And third is financial risk protection, which actually is also social protection, that people shouldn't fall into debt paying for treatment or care. Now, if you look into how women fare in all this, and it is also useful to look at the 6 building blocks that WHO has talked about, because they are supporting UHC, and these building blocks support each other in some way. Those 6 building blocks are service delivery, health workforce, health info systems, access to essential medicines, 5th is financing, and 6th is leadership and governance. Now let us look at each of them. Look at access. We all know how access to health services, and that too quality and effective health services, is fraught with multiple challenges. If you look at hospital admissions of infants or children of say 1 to 2 years in Indian hospitals, I have read one study of Haryana and Punjab, which are relatively wealthy states, northern Indian states in India, where per capita income is much higher than many other states. And hospital admissions were examined, and it was found that most children that were admitted in this age group were all boys. Now, obviously, it's not so that in girls in that age bracket don't fall sick in Punjab and Haryana. The point is, family doesn't opt for hospital care for their daughters because daughters are not valued. Daughters are not there. They're not going to carry their family name after the parents are gone. So, or they do not have property rights, they do not own family names. So, birth of daughters is not celebrated in India. And so, girls' health, and especially if the family is poor where they will have to borrow, girls' health will not be given that priority, that she will be hospitalized and given that care. Instead, they will go to some local provider within the village. First, they will try all the family type of, remedies, homely remedies. And if it becomes little worse, then whoever is available locally, they will go there. So whether that, or these days, the topic that is currently in discussion is NCDs. And we see how more and more women are suffering from that. And in fact, one interesting statistics, if you compare 1990 and 2013 data, you will find that more women are now dying because of NCDs, non-communicable diseases. Now, if you see cardiovascular disease, which women are protected till menopause, but after menopause, there is a sudden rise in cardiovascular issues that women get. And so if you see all those high-end healthcare events like bypass surgeries or angioplasties, angiographies, all those kind of, if you see the data, more men, you will see more men have been treated with those compared to women. So the bias against the woman, right from her infancy to her old age, continues. It's a life, I don't like the word life cycle, maybe, but maybe life course. So throughout her life course, you will see in every field, whatever the health issue, women's status, even as patients, remain secondary. So access, that is one, because families don't give importance. The private, it's mainly private healthcare when it comes to some of these services. Government services, public health services are inadequate, understaffed, and also they have inconvenient timings that are inconvenient to many working people. For example, for agricultural laborers, for poor people in rural India or even in urban India, when people leave early morning work, and today is the labor deregulation era, so there is no fixed 8 hours of working. So people end up working for 12 to 14 hours. And so they can't go to those government clinics, which may be super efficient in some places, but they just can't go. They can't avail. So if general public cannot go, you can imagine with patriarchal disadvantage, women will find it even more difficult to access health services. And so the only option poor people or even middle class people have is private healthcare, which is completely unregulated field in India, which has its own set of problems. Thirdly, even if they go to public health sector, many diagnostic tests are now with payment. So it is no more affordable. And so all those issues about access and financial risk that is given in the UHC just go out of window for majority of women. Third thing, there is a bias of providers. You know, like I told you that I'm mainly talking about cis women, but I'm aware of issues of other women, other women who other persons who identify as women, sex workers, trans, elderly women, single women. None of these categories get treated respectfully in government health facilities, and that's why they don't even go there. They have to go to private health facilities if they want to get some help, which puts extra burden on them in terms of finances. So this whole access, I mean, those three key dimensions of UHC is far away from majority of Indian women. In India, I mean, Vibhuti will tell you, our labor force participation rates are declining, and more than 90% women are in what we call informal, which is actually not correct, but unorganized sector of work, which is completely unregulated, low paying, low dignity kind of work. And so these women have no say anywhere in this, or no rights protected in this whole scenario. If we go to the area of, 1 minute. This is my point. Quality of services. Am I audible?
Yes, you are audible.
Okay. So, as I earlier said, since they have to go to private sector, it becomes high out-of-pocket expenditure and indebtedness, and quality of services is also poor. Even in private sector, that is a huge sector in India, the services are not necessarily of quality. They remain poor in many cases, and women who were formerly from untouchable castes, whom we call Dalits, or tribal women, and the other categories that I mentioned, it could be a very elderly woman, sex worker, trans, all of these women, they are not treated with a lot of respect and dignity in private sector either. So quality of services remains a big issue. Now, if we look at those six building blocks, some of them, there is a commonality in that 6 building blocks and these 3 dimensions, but I want to bring your attention to two important things. One is health information systems, which is very important. And these days, everywhere we talk about data. Data is the new gold, this, that, and other. But data remains a major area of concern in India because we really do not have real-time data, segregated data in any field. Jagori, I shared with you a link on our study on occupational health hazards of women domestic workers. Professor Linda may not be aware of this phenomenon, but in India, there are millions of women who work as domestic workers or what we call house help in many households. There are different categories among them. Some are live-in, some are part-time, some are full-time in one household for one day, and they all have their own sets of health issues. I have shared that link, so maybe you need not. I'm getting some disturbance here. What is this? Confirm your speaking language. Okay. Yeah.
Must be artificial intelligence, AI.
Okay.
Not
okay.
Not human.
Okay. Yeah. So I will not go into the details because we don't have that much time, but you will see there that to begin with, their workplace, that somebody's home is their workplace, which is not defined as workplace in any Indian law to begin with. So if they meet up with an accident there, and there are cases where they get electric shocks when they are cooking and they're using electric appliances or using a washing machine. Sometimes they fall while cleaning the high ceilings, they fall off and have fractures. Sometimes there are sexual assaults. And for all of this, they have to pay themselves. Very rarely the employers have any responsibility, and there is no mechanism that employers will be made to pay for their health expenses to recover. Also, if you fall sick and if that sickness is prolonged, you lose your employment immediately, because there are so many women out there who need job, and domestic workers are one of the easily replaceable workforce. So in absence of any protective law, we talked about social protection, economic risk, all that. There is no law to provide. And this sector, and mind you, this is one sector I'm talking about. There are so many women in mining sector. There are so many BD worker women. There are so many women who are doing asbestos work, and they suffer because of the work, which is not, as it is, we consider having a good health individual responsibility. Whereas WHO or Health for All definitions, they all tell us that it is not individual's responsibility. It's an outcome of so many factors. But an individual is supposed to pay for the ill health that is caused because of work, without which the individual is not able to survive, because they have to earn whatever meager wages they get in those hazardous kind of industries. So health information system, we do not have a count of how many women exactly throughout India are domestic workers. So in absence of any data, any evidence, we cannot expect any evidence-based program or policy. And that is true in many areas. That same is true for sex workers. We don't have the count. We don't have the count, but we have very punitive and criminalizing kind of laws and policies, which is completely violating their human rights, and which does not talk about social protection or equity, the basis on which UHC or many other frameworks are based upon. So my point is, we all need to raise our voice against this injustice and this gap. Look at the health workforce. In Indian health workforce, if you see, there are doctors, and I can see a few of them are present here. But otherwise, women are mainly at lower rungs of our health system. And we also are audacious enough to call them volunteers. You know, we have a sector, a scheme-based workers, women workers, who are called ASHAs. Asha in Indian language means hope. And the full form of Asha is Accredited Social Health Activist. And she's paid pittance and she's dumped with lot of important health activities on her head. So I see a parallel, how women perform all those unpaid care duties within the family. It's the same way women are performing unpaid care duties for the state in the form of Asha. And they are not unionized. If they are unionized, they are penalized. Ashas and Anganwadi, as we call community health workers, which are part of central and state government for health force, who are our frontline health workers, and even they were not provided proper protection during COVID. And initially, the government announced that in case of serious illness or death, there will be a compensation to the family. But later on, the government did not pay. So that is the state of our health workforce. And we have to continuously talk about that health workforce, whether it is men or women, it's applicable to both. They need to have fair working conditions. Currently, their working conditions are not at all fair, and so it leads to many times patient and doctor or patient and other healthcare providers conflicts. Things become very violent at times. I think my time is running out. So let me just talk about one important aspect of financing. Because without money, all the big talk has no meaning, right? They have to put money where it matters. I don't know what is happening with my, okay. Now I'll tell you, in Bombay, and Dr. Padma may share with you, in Bombay, Dilasa, the first ever hospital-based counseling center for women survivors of violence started. And that program later on was accepted within the system by the Municipal Corporation of Bombay. And the head at that time, she was sharing her experiences. That if you look at the data in that part of India, Maharashtra, Gujarat, that part of India, you will see many burn cases where women burn themselves or they are burnt by their families. They're put on fire, which are different types of marital violence, mainly for what we call dowry, or some other reasons, because she's probably not bearing a male child, or they want to get more money from another person, so they want to kill her, and so that the son can marry another woman and they can get more money from that family, whatever the motive. But many such burn cases happen in these states, and so she wanted more burn wards. And the top management of Bombay Municipal Health Department, they shot her proposal down, and they sanctioned budget of crores for new CT scan and new cardiac care units, ICCU, which need those kind of machinery within few seconds. But she was not allowed to go for even 2 extra burn wards. So that is the priority, because as I told you, with NCDs, whether it is private sector, whether it is public sector, and if you look at the insurance, because health insurance is currently dominating our health services and overall thinking and financing, and it's insurance based, which profits the private players, not the public sector. So if you see all those claims, maximum claims are from men. Maximum claims are from men from private hospitals for tertiary care. Here, the poor woman who might have tried to take her own life by pouring or setting herself on fire, or maybe the family members had set her on fire, whatever may be the case. For her, there are very few wards, few services available, But in every public hospital and in every private hospital are overflowing with those wards, those machines. So currently we will see that these kind of considerations overtake what are the field level experiences of women and the needs of women. And here comes the crucial issue. All the feminists who have been talking about gender budgeting, gender budgeting has again become a very term in vogue. Everybody wants to talk about gender budgeting, and what they do is they have those fixed 4 items where they allocate budget. Now that is not gender budgeting. Gender budgeting should correspond to the needs of women as is found out through surveys and through data and through that analysis. That is not happening. And so this kind of skewed kind of priorities have taken over in health field also. Health is not exceptional. There are other fields where the similar considerations are happening, similar things are happening. And so women's health in India, I will end in 2 minutes. Vibhuti, my time, 2 minutes? I have 2 minutes?
Yes, yes.
Okay. So in India, if you see, right from her birth till her death, the state is interested only couple of times in the survival or in the well-being of girls or women. In the infant mortality, that age, because any fall in or IMR getting worsening, we will get international flag. So we have to do something there. So they will pay some attention. Till the age of 5, the girl is looked after little bit. Then between 5 and 11 or 12, nobody is interested in that girl child. After 12, again, the interest comes back because now she is in a reproductive age. She gets her into puberty. And so she may produce children. And there is an obsession that India's biggest problem is population growth. And so anyhow, we have to control the number of children that the woman is producing. So throughout her reproductive age, the government focuses only on that part of her life. So it's not SR or SH. Sexual rights, sexual health, we are not concerned. We are only interested that she has only 2 children. And once those 2 children are produced, we want her to undergo the tubectomy operation at a very young age. Again, once she has completed her family size, once she has had that tubectomy, and the mean age of tubectomy is coming down and down. Currently, it's 22, 23. So once she has done that, again, we are not interested till she dies. Because now she is no more producing children, so we are not interested. She is not a threat. That is the state of women's health, to put it in nutshell. And given all this, then what we want and what actually needs to be done. I mean, we have been saying it ad nauseum, but we need to keep highlighting this and raising our voices again and again. First, recognize healthcare as a right. And this would bring fundamental changes in the policy. And second thing, it has to be tax-funded public health and not insurance-based model favoring private sector. Third, recognition of different needs of different women at different times of their life course, and design health services delivery accordingly. And fourth is integrated health services, preventive, promotive, curative, rehabilitative, and palliative. These are some of my thoughts. It's a vast area, I know. And keeping the time limit in mind, I'm sorry, but I decided not to give too much of data. Otherwise, it takes a lot of time. But thank you very much. Vibhuti, over to you.
Yeah. Thank you, Jayashree Velankerji, for providing such an overarching concern, rooting it in the political economy, and also raising the collective wisdom of women's movement over last 40 years, and also the role that WHO has played, and ending with the 4 extremely important points that what we want is a text-based public health care facilities rather than not the insurance-based privatization of health. And I think your 4 Ps were also extremely important, and this is going to provide it that your inaugural address has set the tone for the remaining 4 days. Thank you very much. Yeah, great session. Yeah, who has written that? Yeah, Aishwarya ji, you can speak. Any participants would like to ask question or share experience? Hello? Samprita. Samprita. Yeah, please make an announcement. Yeah.
Linda.
Thank you so much, ma'am, for those insights and perspectives. Now the floor is open to questions. Anyone who has questions can raise their hand or write in the question and answer box. Yes, Linda, ma'am, you can go ahead.
Thank you very much. I would just like to congratulate Ms. Velanker for a very interesting presentation, very enjoyable, and of course, giving much knowledge to an outsider like myself, who I don't really know the Indian context that well. But I would just like to point out that I do understand the kind of domestic service situation in India after having visited many times. But also, I'd like to point out that it's not just in India. We are currently, seeing a resurge of the same kind of activities in Sweden, which is really a well-developed, first world country or whatever you want to call it. But just the ability to use the labor of unorganized women is becoming a part of the mainstay, even of the Swedish government. Here, the argument, of course, is that we want to preserve the rights for middle-class, well-educated women to be able to work. Therefore, we need domestic servants in the household. That should be debunked, and we're currently trying to do that. But I just wanted to point out that not only is India experiencing the situation. Thanks again for a very interesting and very, giving presentation. Thank you very much.
Yes, Aishwarya ji and Christiana ji, you can go ahead one by one and ask your questions.
Hello, I'm gynecologist. So, seeing the how reproductive care is provided to women, it's very disheartening for me. And I'm at this stage that I no longer can work in such environment. So, since a year, I was reading a lot of material related to it. But in medical community, not majority of people are aware of how women are treated. Nobody wants to accept that we are not treating them with dignity, even if we say that dignity is our main factor during service provision. So this platform allowed to hear such deep insights today, that somebody is talking about it, and also understanding the informal women sector. There's some different word was used, I forgot the word, but I loved that insight that yes.
Unorganized.
Unorganized. Yes, I was taking notes, but I missed that word. So it is very heartfelt for me to see that such kind of discussion is going ahead, and I would like to be part of such kind of discussion. So thank you. Yeah.
Thank you.
I have sent you the link. Please read this report.
Yes.
Yeah.
Yes. Jagori, I'm going to follow now the how which kind of work is going on, and yeah.
Yeah. Christine.
Hello, everyone.
Yeah.
Can you hear me?
Yeah.
I'm an internal medicine physician, and ma'am, I have noticed everything that you have mentioned from the start. Like a woman, as soon as she is born, it's as though in her life is tagged as less important, and that colors her experience as she goes through the healthcare system. And one of the something happened very recently. I had lost a young patient who was admitted under me. She was only 20 years of age. She was younger than me, so I was pretty broken up about her death. And I had taken leave because I wanted to sort of cope. So I had taken leave. I was at home and I live with my extended family. So when I was just talking about her death, my mother-in-law, who comes from like a decidedly very patriarchal background, told me, yeah, I understand that your heart is broken, but at least it was a girl, right? It was not a boy that died. And like, I just was taken aback, like, so much. Like, from where I am, like, with the educational background and kind of things, it's understood that women are treated as second class citizens, but we don't really voice it out. To hear somebody just say it like that, and I think that she believes it. I think the place where she is from, everybody believes it, that as a woman's life is less valuable. And it's all because of the social capital that is ascribed to men, I feel. Like a man, they say he carries on the family name, he can inherit the family property, and, he earns for the family. And um, it's so unfair that it's not that women wanted to be disenfranchised or wanted to stay at home, wanted to not have all this social capital, right? It's like you stripped us off of all agency and then you told us we are not important because of the fact that we don't have that agency. So yeah, it was really heartbreaking for me, and I'm so glad that I'm a part of this discussion, and I hope that I would learn some actionable steps going forward, that I can implement in my own practice. Thank you.
Ma'am, can I say something?
Yeah.
Do we have the time?
Yes.
Yeah. Ma'am, you were talking about the 3 dimensions of UHC, universal health coverage. One was access, one was quality, and what was the third one? There was some disturbance. I couldn't hear it.
Financial risk protection.
Okay.
That
Okay,
no
ma'am.
one should fall in debt because of the treatment or health services that they avail of,
Okay.
because of which, and we have seen during pandemic what happened, or even for any ailment these days. Suppose somebody has a TB, families get indebted. That is
Okay.
one of the main reasons of indebtedness of Indian families. Health expenditure, out of pocket health expenditure.
Okay,
And
ma'am.
so, and that's why women's health again gets neglected, because no family wants to get indebted because of women's health issue.
Okay. Okay. Ma'am, there's yet another question I have. We do know that, both in the urban and the rural areas, women's health is at a very, at the rock bottom typically. So if you were to make a comparison of rural and urban, how bad is rural? I'm just blatantly assuming that rural women's healthcare is even at a worse level. So how bad is it on a comparative scale?
See, rural women's health is bad because there are no facilities, but let us not forget urban poor. Their health status is also equally poor, and sometimes even worse.
Okay.
Especially
Okay, ma'am.
sanitation, air quality.
Yeah.
Because
in rural areas, they sometimes they have a very small piece of land, something there in the village, some support system. Garden. In urban areas, they have no such support. Absolutely no support.
Okay. Okay, ma'am. Yeah, thank you.
Am I audible,
Wait,
ma'am?
Can I come in?
Yeah.
Vibhuti, there are 2 other hands.
Yeah. Bhavya Singh, Dr. Manorama Bakshi.
Okay.
Yeah.
Can I come in, ma'am?
Yeah.
Ma'am, depth in your presentation, actually speaking from the ground, because I myself have been working with the high priority districts in India. So the way you talked about, I have traveled 184 high priority districts wherein maternal mortality and infant mortality was at highest level. So when you spoke about tuberculosis, I could connect it to the, Mehboob Nagar, Adilabad, wherein the women are just 21, 22, and they are having 2 babies and tuberculosis is done. I can refer it to the so many states in in Haryana, wherein the women are not even aware like that they have been given IUCD.
Yeah.
Unka permission, they are not being even asked. And जब उनको आप when you ask them in local language, तुम्हें सुई लगाई गई है? She says वो क्या होता है? Whereas we see the reports and we see already IUCD has been provided to that woman. So those things are, ma'am, the real facts. You spoke about the ASHA workers, wherein you spoke about the unpaid kind of work from ASHAs. ASHAs are actually performing 51 core duties, and that they have to register. And ASHA's catchment area is 1,000 in the normal, and otherwise, if it's a hilly terrain, almost 700 people is her catchment areas. I think there also we need to have a strong advocacy, not to keep that much of catchment area to the ASHA when she has to cover all these 50 activities. I think we as public health professionals have to bring it forward, like how we can bring a load a bit down. Now you also spoke about ASHA and ANMs. The difference between ASHA and ANMs is ASHA gets money only as honorarium. If she will do one PPI-UCD, okay, 500. If she will, there is a space between two children, okay, another 500. Those kind of things are happening. Or if there is a C-section or this thing, then she will get 2,000 rupees. For a mother, they will get 2,000 rupees. Those kind of things she gets. On an average, around 3,000 to 4,000 rupees for doing all her work. But within the Anganwadi workers, they have a basic pay, at least basic honorarium. You're not vis-a-vis linked to their activities, but they get 3,500 or 4,000 rupees. That is one difference, which I think should be applicable to ASHAs. Some states have started giving them 1,000 rupees apart from this, but I think it's very
Meager.
and in fact, some of the states, because the concept of ASHA was started from Chhattisgarh, Mitanin. And once when I was talking to the Chhattisgarh people, they said, you people have spoiled these ladies. Our ladies were doing it without any will, and there was no grudge. But now they are talking about ye nahi mila, wo nahi mila. You also spoke about, madam, about the NCDs. I want to bring this as a public health professional. Even though the women are living more, almost 73 years, and the men in India are living as per the latest status around 69, but unfortunately, most women above 45 are having at least two major chronic diseases. So, which is a cause of concern. Even though the men have more of the chronic heart disease, but women die more of the chronic heart disease. So these are some of the facts that we have to look into when it comes to women. And one of the major things that I see, ma'am, is that whenever the research or survey is done of any disease, or we are doing the clinical trials, it is hardly 1/3 of the women are being taken. So obviously, when we don't have that coming out from the women, from the surveys or from the clinical trials, what is actually needed for the women, so that is why the policies, and it doesn't inform the right kind of policies. And one more thing I wanted to say, madam, one thing good, that this health budget has a provision for women, ASHAs, especially ASHAs, Anganwadi community mobilizers, to have that Ayushman Bharat scheme, even though they have not provided it to elderly care, but at least these health workers have been provided with Ayushman. So I will end up with this positive note. Thank you, ma'am.
Okay.
Thank you, and pleasure always to speak, hear you.
Thank you.
I think there are two more raised hands from
Mm.
Bhaviji and Bhavyaji. So you can go ahead, Bhaviji, and then we can take up Bhavyaji's question.
Your talk is very informative. Someone who is to this space. Hello, am I audible?
No.
You need to unmute. Here it is showing.
No,
you
she
unmute.
has unmuted, but maybe there is some problem with the connection.
Okay.
Yeah,
Who
Bhaviji, please
else?
try again.
Jyoti Dubeji also.
Bhaviji, please write your question in the Q&A or chat box.
Yeah.
Your
Yeah.
voice is not coming.
Can I ask a question? Because
Yes,
my name
Jyoti.
was mentioned. Okay.
Yeah,
Hi,
Jyoti.
good evening, everyone. My question is, I come from an organization where we had this presentation about women health and equality, and we were given this realization that a lot of tests were done on the basis of patriarchy. For example, the reason of a heart attack for a man is different than the reason of a heart attack for a woman. but all the medicine and all the tests are done on men. So the medicines what we have is based on men heart attack than women heart attack. So now we realize our finance minister, Mr. Nada, is coming up with the One Health mission. So my question is, how much is the concentration on women health in that mission?
Okay, I didn't get the question.
Shall I repeat the question?
No,
Manorama,
I think this is regarding the union budget's provision. It comes
Yeah,
to
yeah.
less than it
Manoj-
comes to around 2.8%, and there is hardly anything about gender, because I have read the budget. It mainly talks about the overall and more of privatization. Everywhere it is public-private partnership or private sector. Even insurance is also private sector. So yeah,
Ma'am,
Manoramaji, you can also supplement.
a
Yeah.
very small submission I have. I think this question was about the One Health mission she spoke.
Yeah, One
And
Health
one,
mission, yes.
Jyotiji, was it One Health mission, if I am not mistaken?
Yeah, exactly. Because I
Jyotiji,
believe,
actually, One Health mission was introduced, even though One Health mission has been going on almost for more than 3 decades, but
Yeah.
it got into more momentum post-COVID because they
Yeah.
realized that from animals to from monkeys, the COVID has come to humans, from humans, like if you will see TB is going from humans to the bovine, buffaloes. So that is how this One Health mission was coined. And there are 13 ministries that are working on this One Health mission. And it is as per the budget, it is the prerogative of each ministry to keep some budget for the One Health mission that will ensure that there is no spillover of the diseases or diseases going from. So it is that taking care of the whole ecosystem that includes the animals, plants, oceanography, everybody is involved, right from the Minister of Health to zoonotics to NCDC division, non-communicable diseases, Minister of Environment, animal wildlife, WII, Wildlife Institute of India. So they all are the part of this One Health mission, so that they can look into the genomics, the whole genomic scenario, and how we can contain the diseases from moving from one animals to birds to humans. So that is the basic concept of One Health mission, and the funds were allocated. But
ma'am,
they also had, ICMR had taken it up. CCMB labs have been introduced across India. Almost 50 labs have been introduced so that they can look into the genetics and surveillance of the program. What is the disease surveillance? What is the disease patterns of animals? How we can see that some diseases are coming, zoonosis or zoonotics are coming. So, but how much functional these 50 labs are, that is the question. Even though they have been equipped with all the equipments, but they don't have the capacity development. So, I mean, a lot of things government is considering. When it comes to this AMR, what we call antimicrobial disease resistance, a lot of things are happening. But this is not vis-a-vis only gender. This is vis-a-vis the whole ecosystem One Health is about. Thank you, Jyotiji. This is briefly I could explain you.
Thank you.
Thank you so much, ma'am. I think that's the end of questions. I don't see any more.
Can I just say one line?
Sure, ma'am, sure.
Yeah. Okay. There was some discussion about NCDs. Yes. You know what we have to remember, and that definitely has a gender angle also there. One of the reasons people get NCDs, because we have seen that now at a very young age, people are getting cardiovascular disease, which was not the case earlier, right? And the reason or the causal factor is underweight babies being born. If you are really underweight at the time of birth, very less weight, which is linked in Indian situation to a woman's poverty and nutritional status. And we know India is, we can probably announce ourselves as anemia capital of India, world probably. Every second woman is a anemic woman. And even in men now, the prevalence of anemia is going up. On that nutritional global index, our place has fallen off. And so I would expect the government to spend all those, earmarked amounts that they had talked about, ICDS, this, that, and other, introduce eggs in midday meals. Those kind of measures are required. I mean, One Health Mission, yes, we need to talk about all that also on that front. But what happens when it comes to budget, everyone wants some catchy headlines and something new, and many a times this new thing is always pushed by private sector. It will come out after some time who was the mover behind that. What I'm saying is we need public health measures. We should announce national emergency over anemia. I mean,
Agree with
NCD
you.
prevention, you will set up so many different missions, so many different programs, and so many policies, I mean, insurance policies. What are you doing about prevention?
Madam, agree with you.
He put food on people's plates, especially women's plates and girls' plates, because it's poverty and patriarchy come together. And that's why a woman wouldn't have enough food. She will cook, she will serve others, but she will not eat. We have to change that. If we have to tackle NCDs, some of the NCDs, all NCDs will not be taken care of by this, but this is what I want to say. When we think about engendering gender concerns in health program and policies, this is what is the reality, India's reality, and what is the immediate requirement. That dialogue and that synergy between reality and policy is not present at the moment. We have to all talk about that. Thank you so much.
Jaya ji, just one point. Anemia
नहीं,
मुक्त
वो
भारत.
मेरा नहीं है, वो विभूति तय करेगी क्योंकि अभी दूसरा सेशन होना है ना, तो sorry.
Vibhuti madam, just one point. Anemia Mukt Bharat was started in 2011. And Anemia Mukt Bharat had iron supplementation from 0 to 6, 6 to 18, and then 18 onwards for mother, children, everyone. But irrespective of that, NFHS 5 shows us that the children, especially when we talk about the 0 to 6 age group, it has gone up to 60%. It has gone rather up. So completely agree with you, Jayaji.
Yeah, Dr. Manorama, I would like to point out, anemia happens because of, less hemoglobin. Hemoglobin, we are just putting iron in women's or whoever's body. Where is the globin? That comes from proteins. We are missing out there, just feeding, and those iron tablets cause a lot of issues. Some women get diarrhea, some women get constipation, and they throw out. Yeah. They just throw those tablets out. We need food on our plates. Okay, sorry. Thanks a lot, Vibhuti.
Thank you. Very, very
informative
session. Yeah, there are
few
more
more
questions.
Also, Patel, few more questions.
Okay.
There are two. You can read out the ones on the Q&A. And Kamlesh, Guliaji, please be brief.
Yeah. Oh, yes. Can you hear me?
Yes.
Oh, wonderful. Ms. Jaya, it was so nice to hear you. You touched on actually a very valid point. So in the discussion came the prenatal factors. That is something which is very, very serious in these days. I am a sleep scientist. So we found that, we are changing the networks of a child before the birth. We are not producing healthy babies. So, this is a current era's problem, especially the sleep. I am previously, everybody has talked about malnutrition. Even now it's a malnutrition, but, not getting sufficient sleep during the pregnancy, which is nobody is pointing out. I have brought lots of, basic research evidences that hypertension, ADHD, depression, the mother has depression. And look, the scenario is changing. We are nuclear, families. Nobody has time. Everybody is working from home, from here and there, not getting enough rest. So they are not having available information. Even medicos don't have so much of a guidelines. So this is the one we are trying to highlight through various researches, various platforms. However, this is a one hidden area which is in a way, it is coming up in a gross way, because depression, ADHD, it is rising. Nobody has heard of these things, in an Indian scenario. I remember pregnancy in any family, whether poor or rich, it is celebration. Now it is like, not
Yes.
too much emphasis on the health. So this is something, it bothers because the child who has, at a fetal stage itself, you have disturbed their networks. They cannot live normally. They have, and even the second thing is about youngsters. We talk of unorganized sectors. I deal with the PhD students. I deal with the students. Many of them, I think most of them, they themselves come and say that we are not able to cope up. We have anxiety. Anxiety is become so common. Depression has become so common. They have money, but they don't know how to live with their time. These gadgets have spoiled their mind. They are not able to discipline their life. So I think lots of awareness is required in this society now. The major issue, I can understand malnutrition, all those things, those are the big jargons. But, to lead your life in the current era, it's a major issue. So kind of you to have all these sessions. I think we should be bringing about more and more, especially the women, because women have a major role and they are the sufferer also. Thank you so much.
Thank you. I think Christian is Ratna Kiruba. I think she has written in chat box if you like to share. Hello, are you there, Christian? Hello?
No,
She has written about abortion. Okay.
Okay.
Maybe she's not able to contact. She has written about abortion and what can we do.
Yeah.
Second time. Okay.
I think there's one more raised hand, ma'am, from Jyoti Dubeji.
Yeah.
He has already asked.
Oh,
She
sorry,
has
sorry.
asked.
I did not. Yeah, I did not
Kamlesh
know.
Guliaji has also asked. Only Christian is
Yeah,
his
yeah.
left out. That's it.
Yeah, yeah.
But
And there are two more questions in the Q&A box. So
Yeah,
I'm reading
yeah.
them out. Will you take them up now?
Yeah. She has already
First,
taken. Okay. Yeah. Go ahead.
so the first question is from Shrishti Stuti Roy ji. She is asking, she wants to know if there is a framework to regulate women's unpaid care work, and will we ever be able to pay our women for it in any way?
Chicken and egg. Okay.
First, let them
Yeah.
pay for their unorganized sector work. That will be a big test before we go on to unpaid care work. Who will pay? The family will have to pay. Who will pay? The state will have to pay. If we ask
Okay.
those, and some of those, when I think of those demands from early parts of my youth,
Which is
every 8th March, we would make some demands, and we would announce those demands, and we would routinely ask for community kitchens. We would talk about how things were done in Soviet Russia, community kitchens, community laundry, community creches. I think that vision is still very much valid for women. And we need to go back to that. What is welfare state? It's not rocket science. We have to talk about it. Now, neoliberalism has taken us far away from that vision, and everything is individual. And it is seen as individual success or individual failure, which we have to counter. We are social beings, and we need those social structures. I mean, in India, Rajkumari Amrit Kaur ji, if we read her demands as Congress Party secretary before independence, the kind of recommendations she had given, they were so ahead of her time. So we have to go back to that vision,
And the framework is there because now Government of India for the first time has given the data on unpaid care work.
Yeah.
The time utilization study 2019 provides, and they say that Indian women on an average are putting in 10 times more labor effort for the unpaid care work than the Indian average man.
And it's not only burden, but it's also opportunity cost.
Correct.
that they are paying. They could have earned that much more in those many hours if they were not to do that unpaid care work. So they lose out doubly. Because unpaid care work, I mean, all those household chores, let's be honest to ourselves, it's so monotonous and boring at times, backbreaking, but every day you have to do it. So women have no choice. So we have to alter that.
Right. Yeah.
Yeah.
And sharing also has to be there, sharing of the
Yes,
unpaid
yes.
work, care work by everybody. Yeah, not only.
Okay. Thank you so much for your positive feedback.
Yeah, thank you.
One last question from Bhavi Palrecha. She has asked, what are some of the actionable steps we can take to support the much needed change?
Okay. I had given 4 or 5, but there is actually a long list, but I had taken very broad points which will cover many aspects. Like I said, first thing we have to start, and we have to start thinking and convincing ourselves first. That, ye revdi ka culture, we have to forget this phrase from our heads. Welfare is citizens' right. We have to be very clear about it. And it is tax funded. No government is doing any favor to anyone. It is tax funded. And so we should demand tax funded public health services. That is that one thing captures so many things because it talks about political economy. If you have to do public health, strengthen your public health sector, you have to regulate your private health sector. You have to put more money in public health sector. So you are changing your priorities. That one umbrella demand will take care of so many points. One demand, that real-time data, sex segregated data. Because right now we don't have data. We don't have data on abortions. All the gynecologists in this, or all those doctors who have done some amount of work in rural areas sometimes during their postings, they all know. We don't have data on abortions. We don't have data on how women make those decisions. If we want to alter somebody's thinking, that go for safe abortion. I am not interested in legal or illegal. What matters is unsafe because that may take her life, and every life is precious. So we have to start with that.
Thank you.
Yeah. Thank you.
Thank you.
Yeah. Thanks. I will take your leave now.
Yeah.
Okay.
Yeah.
All the best. Amar, thank you so much for being there.
Patiently, yeah. Now it is his turn.
And
He'll
silent
carry forward.
listener, I have learned a lot from Amar, so I don't know what Guruji thinks about my lecture, but he'll text me.
Okay. No.
Bye. And all
Bye,
the best.
bye.
Bye.
Okay, see you. Bye.
Thanks.
After
Bye.
long.
Bye.
Yeah.
Yeah.
Thank you once again, ma'am, for such a lovely session. Moving along, we have our second session of the day on healthcare system and gender division of labor by Dr. Amar Jesani ji, independent researcher and teacher, bioethics and public health, editor, Indian Journal of Medical Ethics, visiting senior fellow IMPRI. Thank you for joining us, sir. Over to you.
Can you allow me to share? Okay. Yeah. Okay, good evening to everybody. And I must thank organizers for allowing me to change my schedule because I was supposed to speak after 2 days. And since I'm traveling from tomorrow, so thanks a lot for preponing my session to today. Well, I come from medicine, but I'm not a practicing doctor. I never practiced medicine, so I don't have a very strong grounding in the way the medicine is practiced. But over the years, being from the medical school, I have done a lot of research on health system and medical care, and what I'm going to talk is going to be based on that. This is the journal we have been publishing for last 31 years. This is a peer-reviewed index journal that is called Indian Journal of Medical Ethics, and you may find a lot of critique of health system as well as medicine there, both from general human rights issues in the healthcare as well as from the equity issue, particularly gender and other aspects. Now, before I go into today's presentation of mine, I thought I'll just make a couple of comments on what Jaya was talking about. I think it's very important to understand that we cannot do much policies about health. What we can do are the policies on the health care. The health is determined by many, very different ways. But what you can do as a policy is to provide the conditions that can help people to be healthy, So to be healthy is not the right, but to have conditions for becoming healthy is the right. I think that's where we can go into the real way in the way system is organized. So within that part, what I was impressed by Jaya's thing was focusing a lot on universal access to healthcare services, and it should be publicly defined services from the texts. The universal access has 4 components, as she talked about: the availability of the services, the access, which includes the economic access. Acceptability is very important, where the issue of culture, medical ethics, and the respect for the patients and all comes up. And it's also an issue of quality of the services. All those 4 are very much part of the, the human rights discourse on the healthcare. But throughout that, I think we must keep it in mind, and keep it also in mind from our experience of welfare statism of the Europe and part of North America, is that the equity issue must be at the center from the very beginning. If they are not there, then you are in trouble. Because what happens is that if you have a public health system, but if the public health system is highly biased, saying that everybody has equal access, but when you go there, you find that you are not treated well because you are a woman, you are a Dalit, or you are a Muslim, then that creates problem. So I think not just gender, but also many other equity issues, they should be brought together because we require that intersectionality. So it's not all women may not be treated badly by the system, but there are a large number of women who come from lower caste, lower socio-economic orders. They may be treated even worse than the other women, So every woman is treated with certain bias, but then there are others who have burden which is much double or triple than just being a woman, So those areas are equally important, and we need to integrate that from the very beginning. Otherwise, as it is happening in Europe and other places, that the welfare system itself is abandoned by the people for whom it is meant for. My first exposure to the feminism and its relationship with the services in late 70s and early 80s, when I started reading literature, came from the very strong critique of the welfare state, saying that this welfare state is not treating us well because we go as a women and we don't. Or black people will say, no, we are not being treated well there. So it is a public system, it is a tax-based system, but it also carries the image of the society, its hierarchy and its ideology there, its patriarchy and its class structure, gets reflected. So I think that is very important. I made this point also because it has a connection to what I'm going to talk, and that is about the health system and the gender division of labor. And I think when I talk about gender division of labor, it's nothing but the patriarchal hierarchy within the medical care system. I have got half an hour, and I hope another half an hour will be sufficient for discussion. what I'm going to do is look at some history about healthcare workforce and all, and hospital system. Then also look at the gender roles and relationship within clinical medicine and hospital care. And third is talk about the interaction with patriarchy state and the market, how it influences the placement of men and women in the healthcare system. And then last thing is something about how to overcome the gaps of gender gaps in the system. An overarching point in India, I'm sure all of you know it, is that when you look at the healthcare system in India, you find that it's full of women. What Jaya was talking about, Aisha, who runs into hundreds of thousands, they all are women. You go into the auxiliary nurse midwives and nurses, they're all, most of them women, even 96% of them are women. Then you come, to laboratory assistants and many other ayabais in the hospital, all women. You look at even medicine, medical colleges, you'll find that it is feminizing. It's a majority of the medical students today at undergrad are all women. Majority of them, almost 55 to 60% of them. But then why are we talking about gender division there, in a system which is full of women, otherwise dominated? And yet, how is it that still remains, a highly patriarchal? I think that is the question we need to overall answer and try to understand in this session. So I'll try to do more of a conceptual exercise on this rather than going into the lot of data. Let me start with the origin of the modern medicine and the hospital system. I circulated one paper which is about witches and witch hunting. The medieval time in Europe and other places, where it was shown that while there was a kind of an organized medicine, which we call medical system of a kind. But most of the services to the masses was provided by informally trained people, and most of them were women, large number of them. They were at the village level and other places, they were the main provider of care. And how in the medieval time, the women suppressors, women healers were suppressed, because the medicine was emerging as a male-dominated profession. Particularly in UK, that England, that history is quite telling. It says that yes, there was the Royal Society of Physicians, Royal Society of Surgeons, the surgeons who came from Barbers, who really took over a position of some prestige, and the apothecaries, who were the ones who were dispensing medicine and at the same time working as healers. They were all strongly male-dominated, almost exclusively made up of male, who ensured that women healers were gradually taken out, and then those who were very resistant and tried to raise their voices, they were branded as witches and burnt, or suppressed. There is a history, and it's a very interesting history to understand, to see what kind of violence that accompanied the rise of modern medicine in European setting. 19th century is the one where the real anchoring of modern medicine took place. As I said, that you had all those royal societies, they were all associations of doctors. The physicians were the most privileged strata within the medical profession. All of them men. They hardly understood any scientifically women's bodies, but yet try to control the entire practice and try to displace all the midwives from the practices. But they were one. Then there were surgeons and there were apothecaries. But they were each one having their own colleges and all their work. So they were highly, vertically separated sub-profession of the medical profession. And there was a huge movement against this, saying that we need to have a common denominator of the doctor. That means once you say it's a doctor, that means everybody has to have uniform qualification, a minimum uniform qualification. Beyond that, you can have whatever specialization you got to carry out. And you must have heard about the well-known journal called The Lancet was established in 1823. And this is editor, Thomas Beckley, the first one, the first editor. They all were, this is the medical journal today, which is very much part of the larger establishment, is the one which was born out of activism of the doctors in order to homogenize medicine, create a legal entity of a doctor, which is recognized by the emergent, capitalist system as an autonomous profession. And that led to, in England in 1857, the enactment of the medical law and the creation of General Medical Council. All the medical councils and regulatory bodies that we are talking about, that we have in every country, their origin comes from that mid-19th century. And what did it do? I mean, how the profession got defined? That it got defined by having a monopoly over practice. This law said that no other person other than the one who is recognized by this council can practice the modern medicine. It says that they are the ones who will decide what will be the syllabus for a person to become a doctor. There's an occupational clause. They decide that even after taking, doing a training, who will be qualified to enter the medical practice? So even if I get MBBS, I have to apply to medical council to get the membership there, registration. So if my medical college is not recognized by the medical council, I will not get registration there. You see, it's very, very, so even a medical college trains me, but that is not sufficient. It has to be according to, so there's it's a very close profession. It makes the profession very, very close and makes it very, very powerful. And then outsiders cannot interfere in your internal matters, so self-regulation. Now, all these things are in modern times breaking down, but at the same time, this is how the profession emerged at that time, and it created a very distinct space within the labor organizations or labor, the kind of division in an emergent capitalist society, and created a space for it, which gave them high prestige, high income, and monopoly control over the healing process. And this is the profession which is born is a male-dominated, largely men. In many countries, women were not allowed to enter. And when women asserted there were separate colleges done for the women where few women will be trained, but they did not have much space within this. And it was only in the latter part that it opens up for the women. So this is when we talk about hierarchy and how hierarchy reflects patriarchy in the larger society, you need to understand that how the most dominant force within the healthcare system, that is doctors, came in the history, in the modern history, and what place that it came to occupy. Now, along with that, when doctors are really solidified in the mid-19th century, it is at that time that another force emerges, and that is called nursing. You must have thought, that the nursing in any kind of medical care should be there all the time in the history of humanity. Yes, there was nursing before nurses came up in the history. Why? Because women were the nurse, very simple. The women have, ideologically, it was understood that caring is a natural attribute of the women in the household. That is their job. So if anybody has a problem, anybody requires care, anybody is sick, The person who has to develop as a carer along with doing other housework is the woman, right? And so they have a natural attribute. They are naturally, having that genetic attribute of certain kind, which make nursing nurses, women as nurses. So yes, that was kind of a nursing was there all over. And if rich person has a medical problem, then they will hire people, women from the plebeian classes to come and help out as a nurses there. And you had, you must be knowing about vet nurses. If you are very rich in the medieval time, you will have a women who are lactating in the poor communities. They will be source for breastfeeding the children. So this was largely an understanding that women are natural carer. What happens in the mid-19th century? As the doctors come up, as medicine as a science start emerging, the whole idea of making change from women being a natural carer to women who could be trained to be a carer, I think that conceptual change comes. And that is when the nurses as a modern profession is born. And the whole thing was headed by, as you know, I don't have to tell you because this story is so well known, that in mid-19th century, Crimean wars are there, and the Florence Nightingale comes, who comes from a very aristocratic background. She is not a poor woman who is doing nursing work. She is a philanthropist who is from the aristocratic class and who gets involved and tries to give a high profile to the nursing work during the wartime when people actually need a huge amount of nursing. And because so many men have gone to war, there are a large number of women who are at home. Many men have died. So we have a lot of widows there. There are a lot of surplus women who are not able to find men because they all are at the front. And this surplus middle-class women get stimulated to follow Florence Nightingale. And that's how you will find that the plebeians who were earlier working in the ill-equipped hospitals, where there was no medical science much, where doctors did not know that before you touch a patient, you need to wash your hands because you might have, you are doing a cadaveric dissection of a very deceased person, and suddenly you run and start doing a delivery of the woman, then you are giving infection to that woman, whose delivery you are conducting. They did not know about it. Right? Science was not developed. The germ theory had not come up. So most of the nurses were plebeians, because there was no nursing having any good place in the hospital setting was not under. So very poor, ill-trained or not trained women were working. And now Florence Nightingale says that no, you can be trained as a carer. And that's how you'll find that in Europe, the middle-class women populates the nursing. In India, it is a different thing because of the caste system where there is a lot of issues related to purity and pollution. So the initial women who comes to nursing are Christian women and lower caste women, and the upper caste women, middle class women do not join nursing. But that is a history of 20th century when nursing comes to India. But here, this coincides with the scientific developments in the medical care. The science of medicine really gets strengthened in the second part of the 19th century, when asepsis, antiseptics, and nurses, these three combined together to transform the whole condition of hospitals, where people earlier used to go to die. Now it changes that people should come to recover from their illness to the hospital. So within some 20, 30 years from the mid-19th century, you will find that hospital as a place where patients can be managed in a very scientific way with the help of the nurses becomes a kind of way of doing medical practice. So many historians will tell you that in history, the modern hospitals would not have happened if modern nurses had not come about. Nurse hospital is also nursing care place, a caring place. And that is established by nursing coming in. And as you can see it, you have all women here. Why? I mean, why only women can do caring? Why only women can be trained to do caring? Nobody asked that question because they have a natural tendency to care. So they can also be trained to care, you know, and that is how once the ideology changes into that, the nursing becomes a women's job. And that also, you know, means that medicine has to create space for the nursing. Before nurses, what used to happen in, say, rich people's houses if somebody falls sick? The doctor goes, house visit. Doctor does both. The nursing care along with the woman, or provides support, or tells women how to do the nursing care, and also does the medical job there, right? So the nursing and medicine were not very separated. Here you will find that with this change, a structure changes, and the medicine which included what is called healing profession. The healing profession has both the components, caring as well as diagnosing and curing people. Now they are getting separated, and the separation, as you can see it, creates some conflict, you know, isn't it? Then there are doctors and now nurses coming. What is the role of nurses? Can they come and take over the doctor's work also? So doctors become very insecure, and they said, no, you will have to remain subordinate to us. So you will find that nursing association, many of them in the past, you know, centuries back, had their leaders were doctors rather than nursing. Even nursing council in India till 1980s, or perhaps 1990s also, their presidents were doctors, most of the time men doctor, you know, and not from the nursing profession. Why? Because nursing syllabus will be decided by the medical profession. That means it should be such that it always remains subordinate to the medicine. So you find that patriarchal hierarchy, which is in the society, comes here. And that was one of the reasons why, despite nursing emerging in the history by mid-19th century, hospitals flourishing by the end of the 19th century, the nursing women were not given recognition, a legal recognition as a council, and given some autonomy in the same way as the medicine was given till 1920. The first recognition of the nursing council is 1920. India immediately, like since India was under British, by 1922-23, the first nursing council also is established here. As I said that hospitals earlier, you know, where this is the history of hospital, which is very intertwined with the history of nursing. And as I said, that rich received care at home. The ancient and medieval times, hospitals were places where poor people used to go and die, you know, for treatment and death. And the plebeians were the nursing who were taking care of it. Till that time, there is a lot of writing that I was reading, which says that the nurses who came from poor background, they had a very strong identity with the patients who were coming from the poor background, because most of the patients in the hospital were poor. But what happens in the later time is that nurses starts competing with the doctor, and so their reference point changes from patient to the hierarchy there. But it's very important to see that you know, the way overall structure of caring becomes you know, so organized that the patient's viewpoint starts creating problems. You know, it doesn't have as much saying there. Anyway, when I was in medical college and when I was being taught about medicine and nursing, I was told by some of them my teachers or in general discussion, that hospitals are like families, you know. You have a family has a head of the family, you know, who is a man of the house, and you have a mother there, you know, wife, and then you have children. So hospital is like family where the patriarch is the man, and the carer is mother, that is nurse, so doctor, nurse, and the children. The whole strong understanding of paternalism that I was taught in the medicine came from treating patient as children, right? So what is the autonomy? What is the issue of consent and all those kind of stuff? We are here to do good for them. They do not understand what is good for them. And so we'll have to push it on them, saying that this is the right way of doing it. And they must accept it because we are doctors and nurses. Anyways, it was very, very interesting. But this is what provided me in my medical college days in 70s. The idea, as I reflected on it, that the patriarchal system is very much ingrained in the way the entire system emerged. So that's why I was trying to understand that how the positions and the roles determine various kind of work. So it's just that in medicine, initially there were doctors. In nursing, initially mainly were women. And you will find that now the structures are changing. The medicine may be feminizing and all. So we will take up that part, feminization of the workforce. But what is important to understand that whether it is feminizing or not, the structure of medicine still remains patriarchal. So whether the patriarchal position of the patriarch is occupied by man or woman may not matter as much as what is the role of the patriarch within the medical system. That is what we need to keep it in mind. So till we treat a job of a doctor as a masculine job, you are going to have a patriarchy all the time existing in the medical system. All the time, nurse's job, if it is looked at, or caring job is looked at as a feminine job, then you'll find that the gendering of the medicine will never go away. So what are these kind of things? Let us look at the tasks that doctors do, which are, central to the doctor's existence, is diagnosing. Nurses are not supposed to diagnose what is the problem with the patient. It is the doctor who does it. Although nurses may know how to do it, but they are not supposed to do it. They don't have a formal power to do that. Now there is a change, like there are a lot of nurse practitioners coming up, and those issues are opening up. And that way, I would call the whole issue of overcoming the gender barrier in the organization of medicine is gradually happening, but it's still a very incipient stage in India. But diagnosing is one. Determination of therapeutic that is offered to the patient. They decide. I remember myself as a intern after I finished my undergrad medical thing, and when I went to a district hospital as an intern, I remember suddenly called for an emergency, an asthmatic patient. I went there, examined patient, say, oh, it's a patient of asthma, easy to diagnose because this is a long-standing thing, and the patient himself or herself tells you that I'm asthmatic, so you don't have to do too much to diagnose it. But when I wrote down my prescription for the patient and asked nurse to give, she immediately called up senior doctor. She came to me, said, "Doctor, you are making a mistake here." But I didn't care because it was nurse telling me, I am the one who decide what therapy to be given. But she was wise enough to talk to her superior. And when I went there next day morning, my supervisor says that, well, you are still very new. You don't know how to do it right. Your nurse knows the better. You should have talked to nurse, discussed with her. Then you might not have made mistake that you made in this prescription. But they are not supposed to do it. This is the very important part, because this is the masculine part of the medical care. Decision making in the management of all kind, of the patient, is all in the hands of the doctor, and they try to protect it very, very strongly as that autonomous clinical decision making power. All those things. There are many other things I can give you. That what technology that doctors can use, and what technology that the nurses can use. But over the year, you must understand that as any system develops, some of the tasks are shifted. So once upon a time, doctor was identified with a thermometer. Afterwards, you'll find that it is the nurse who is identified with thermometer. When I was in medical college, the stethoscope was my monopoly. So as a young student, we'll go all around with a stethoscope around our neck. Even when we go to buy a cinema ticket, we will have it so that we are given priority to buy it, you see. But same stethoscope today, you'll find less in the hands of doctors than in the hands of nurses. So the tasks are shifted, as well as technologies are shifted, and the identification of various healthcare workers with them. Tasks done by the nurses are looked as a feminine task. Some doctors may be doing it, but it's not supposed to be their job. It is the job of a nurse. Whether nurse is man or woman, doesn't matter. Task in your mind is that of feminine, right? So physical and emotional caring of the patients, implementing the clinical decision that you have to give this tablet 3 times a day, and you have to go and give it to the patient 3 times in a manner as required. Counseling and other supports, all kind of nursing care or caring work that is to be done is by them. A good doctor will always consult nurse, want to find out what is the actual position of the patient and the household and other things, because they know much better. Doctors don't know, because they never ask, because they don't know. They don't want to become very close to the patient, So this task becoming identified with certain kind of gender is very, and this is not actually medicine has a very peculiar way of categorizing various tasks, but it is not very different from what you find in other places. You'll find that when I was young, if we talk about having a typist in our office, it will always be imagined as a woman coming as a typist. A secretary was always a woman, not a man. That doesn't mean there were no men secretary, but secretarial work is a woman's job. And worst part is that these are the feminine tasks which are identified in different professions or occupations, and they are kept under the strong dominance of those who are supposed to occupy the masculine position. So this is a structure, and I think it is very important to keep it in mind when we talk about how do we overcome the gender divisions within the healthcare system. But this gender categorization also influences who will take up which kind of position in the healthcare system. Those who want to play a dominant role will go to the medicine. Those who want to do caring job, they will go to the nursing. As far as the motivational part is concerned, if you say that yes, it happens because of the socio-economic issue, which is what I call intersectionality. It is not just about women, but a woman coming from a better up position or is having opportunities to compete and get into the medicine will get into the medicine. But otherwise, it is easier for them to get into the nursing kind of thing. So the concentration of workers takes place. The other thing is that apart from the nature of medicine, it is also the market, which in the context of capitalism is very important. So within medicine, you'll find that men will go for certain kind of specialty. women will go for another kind of specialty. I remember when I was in medical school in 1970s, 70% of doctors in obstetric and gynecology were men. 30% were women. Today, the ratio is reverse, right? 70% women, 30% men, and yet the gender sensitization of obstetric and gynecology is required as big in a big way as in anywhere else. So just having women is not sufficient, but how the obstetric and gynecology as a discipline functions is very, very important, right? You'll find that in orthopedic, hardly any woman is there. And normally women say, oh, they are all masculine people. They just do this certain kind of job. We are not interested. So it's a very important that how any specialty which is a high demand in the market, you will find that men going in concentrating, whether it is cardiology, or say other places, wherever it is now. You have to find out, which are the ones which are highly in demand. And I think doctors, because of the way Indian health system has developed, they have a very strong sense of market. They normally don't get the state job, in the government system. We have only 10% or less than 10% of our modern system doctors employed in the public health system. The rest are all in private. So when you come out of the medical college, you have to continuously think about how to make your money. And as the medical education becomes more and more expensive, you have to go for lucrative places, and that's how it decides. And so women will definitely, because of that, go into the less important places than the men are able to go. So the concentration, how various sexes go into different kind of places is decided there. The leadership position is again very, very important. Even where you find that departments have a majority of the women, the department head is more likely to be a man. You will find, for a long time in Indian NGO system also, you will find that NGO has a large number of women because it did not pay market rate to them. And as a consequence, women will be joining there, but the head of the NGO will more often you'll find is a man there who is doing it. So this leadership position, I think I circulated a paper which says that, well, in India, 18% of leadership position in healthcare system is with women. That is a very, very low ratio as compared to the majority of the women in medical colleges today. So the feminization, as I was telling you, is a real phenomenon that is taking place in medicine. And yet, all those women who get trained as doctors, they don't practice as doctors. I'm the man who is not practicing, but it is by choice. While women, sometimes not by choice, not practicing. They don't have it because they have to take care of the household. It's said that if your husband is earning enough, why should you be practicing? Earlier, I said that, well, women go into specialization, which is less important. But there was a phase, I think, both in the Western society as well as in India, was that a woman will go and marry a woman doctor will marry another doctor. And you'll find that the union is that of, say, if a surgeon is there, the surgeon will try to marry either an anesthetist or a pathologist, because that becomes a kind of a support structure when a surgeon wants to establish a surgical small hospital. Because that is what they were doing in 60s and 70s, because government jobs were not available. So doctors became entrepreneurs and they established small nursing homes. So husband and wife can work together, but husband always in the dominating position. So as I said, that either they work as under the less important medical position, or they just don't work. And that's how the number that you see in undergraduate colleges, where majority are women, when you go into the post-graduation and super specialties and actual practice, you find that the number has come down. Actually, we don't have data about how many men and women are practicing medicine in India. We don't have that gender segregated data. But there is definitely this impression that I get that when you go in the market, you don't find as many women as you find when you go to the medical school and sit in the medical school classes. And this too, not only India, but also Pakistan, because I have been teaching bioethics in Pakistan for a long time in Karachi, and they also told me the same thing. The majority of their undergrad students are women there. And then you can, you say, oh, it's a Muslim society, how so many women going to for higher education? But they do go, but they don't practice. They said there is a dearth of doctor because practicing doctors are less. Although the doctors getting trained are more from the women. As I said that despite feminization, you don't find women dominating practice and leadership. And so they are concentrated in less market demand places. This is the last one slide. This is about how to overcome this gender division. Overcoming gender division in medicine will require a profound transformation of the medicine itself. Otherwise, if medicine remains hierarchical and keeps mirroring the patriarchal hierarchy of the larger society, then the gender division is going to remain, both in terms of task, that is its own nature of practicing, as well as the kind of people who will be joining them. I was reading this paper by Julie Fairman and Patricia D'Antonio. I circulated it as a background reading to you people. And it is about, how do you redefine or reimagine the nursing in medicine? I think that is what they are talking about. And it interested me a lot simply because it's not about putting nurses in a different position in medicine, but it also critiques the medicine in itself and says that the medicine, if it wants to overcome the gender division, it will have to relook at how it is prioritizing various tasks of it. So one thing is they said is that you will have to start non-prioritizing diagnosis. The diagnosis is the linchpin of medicine, where the masculinity is concentrated. The diagnosing and therapeutics. These are the two where the masculinity are there. So, how you provide treatment decisions and diagnosing decisions. These are the ones which are looked at, irrespective of whether it is being done by man or woman, but as a masculine part of the patriarchal division of labor within the medicine. Approach medical care from the nursing perspective of care. Care needs to be brought at the center of that is the healing of the people who come to the medicine. And that means strengthen the human elements. Now, when I say this, why I say that these are very profound. I mean, this issue should be considered as a caring and humanistic part. Should be very integral to medicine, isn't it? But the problem is that today, sometimes doctors even don't talk to the patient. They don't even touch the patient. They have become so dependent on technologies that as soon as patient comes, all laboratory karwao, that is you get all the X-rays and CT scans and MRI and all kind of stuff. And the doctor is busy diagnosing using those findings. You want to be very objective and evidence-based there. But the interaction with the patient becomes so narrow and low. It is no longer there. I mean, that is one of the major problems. And so that is what nursing as a feminine task brings us. So if you deprioritize the diagnosing and decision making for therapy, and you make caring and humanistic approach as the priority of the medicine, then you are putting medicine upside down and bringing its true element, real work of the medicine to the fore. And I think that is where the gender issues are very, very important in overcoming this hierarchy in the medicine. Technology as you use must be done in an appropriate manner. How all these things you do humanistic one, I think you have to foreground the experiences of the patients rather than just science. Today, because of the dominance of diagnosis and therapeutics, you are foregrounding science to the humanistic experience of the patient. Foreground them and then use science along with while helping the patient to overcome their problem. So science is not discarded, but science is made as a part of the humanistic approach, which is very, very important if you want to combat the gender division. And there has to be collaborative partnership, even if there is a division of labor within the health workers. It has to be equality-based collaborative partnership. And overall, what I'm talking about is challenging the traditional paradigm of medicine. Because this, and there is a lot of critique of medical education based on that. Gender sensitization of medical education, looking at the issue of equity based on related to race, caste, and others. The conscious and unconscious biases and prejudices, all of them are very important, and they all challenge the traditional paradigm of medicine. Another suggestion that I read from few people, which really interests me, I don't know whether anybody has done experiments on it. But why are nurses and doctors trained separately? Why can't they train together? If not entire length of their training, why not certain length of training where there is a common education that they get in the medical school? Is it possible to do it? Because that is where you can overcome the barrier of what is masculinity. If I'm a masculine man, a male, I would not like to do certain things, because I remember, all men will tell you that yes, you get some feminist consciousness and you start doing even housework, but initially you do it secretively and then you do it openly, isn't it? Because your peer should not know that you are doing women's work in the house, But then you gradually open up, right? It's the same thing here, when a doctor is being trained, and doctor is also made to do nurses' work and say that this is part of the caring work of the medicine and learn about it. And nurses who are also being trained in similar circumstances, who are doing caring, but at the same time, yes, you have a mind of your own and you have learned all the basics. So you can also do diagnosis and take certain decisions. And you collaborate, doctors and nurses can collaborate in it. And that is how perhaps you can say the beginning of overcoming the gender division as it is existing. Anyway, I already crossed half an hour, so I will stop here. Wait for your questions, and well, if you need any reference material, more reference material, you can always ask me, send me an email, and I will provide that. Thank you very much.
Thank you so much, sir, for such an informative session. Now I pass on to Professor Vibhuti Patel, ma'am, for her remarks in this session. Over to you, ma'am.
Thank you, Professor Jesani, for bringing such an important dimension of patriarchal structures in the healthcare system, because you also brought in historical reality of last 200 years, that feminization of healthcare services results in subordination of women, and also which are changing also in the gender-based division of labor also sees to it that whatever is considered to be low status and low paid, and we experienced that also in the Russian Revolution. In the pre-revolutionary Russia, the doctor's position was very high and they were highly revered. But we saw feminization of medical profession, where more than 2/3 of the doctors were women, and their wages were less than that of a bus driver or a mine worker. No, so this also happens. Patriarchy that way is such a flexible value system. It's so it finds its ways of persisting subordination. Another thing that we got to know during the pandemic was the WHO's statement that 70% of frontline corona warriors were women, but less than 25% were in leadership positions. Even apex bodies are, even those women who were in the leadership position in the apex bodies, there also it was found that they were rife with mansplaining. Kind of women are to be seen, not to be heard, or women make coffee, you don't make policy. No, that kind of ideology even exists in the apex bodies. So we need to shake up this power equation, and then only the structures and systems which have such a embedded patriarchal bias can be challenged. And I think that is happening also. Increasingly, more things are documented, more experiences are being shared, and also mansplaining has also been challenged, because we know way back in 1975, when in UN body, in the apex body, a woman was told that anytime she tried to open her mouth, she was told to bring coffee and sandwiches. And she screamed back and she says, "I don't make coffee, I make policy." Because in the UN body, you have not gone there to make coffee. So I think that also we need to stick out our neck. And initially, like, people may call us witches or bulldozer, but I think we need to call spade a spade. Women, and that is very important issue. This thing we bring, and we will also get allies like Dr. Amar, Jesani, and so many others who are challenging gender stereotypes in their personal and professional life. Thank you very much.
Thank you so much, ma'am, for such insightful remarks. Now, I would also like to invite Dr. Manorama Bakshi for her remarks. Over to you, ma'am.
I think Vibhuti ji has given wonderful remarks. I think after her remarks, she has already addressed the labor workforce participation, both at in the healthcare as well also. And Professor has already shared a lot of his comments on it. I think Professor Linda has raised her hand. So you better take her comments, because as of now, I don't have anything much to say.
Sure, thank you so much, ma'am. Linda, ma'am, you can go ahead and give your remarks.
Thank you. I don't know if I have anything so profound to come with, but I just wanted to connect to the comments that were made by Professor Patel, that one of the things that I find very interesting in this historical, kind of review is the fact that, it's the need for an intersectionality perspective here completely, because as Professor Jesani, spoke of, the medical profession is becoming much more diversified. It's becoming much more integrated with other types of systems. And if we're going to kind of understand fully, or more fully understand this kind of subjugation, or the way, the inner workings of patriarchy, I think we're going to have to kind of tease out these changes that are occurring all the time. I mean, I don't have India as my background, but in contemporary Europe, in the American experience today, we're finding that many nurses are men, many midwives are male, many more doctors are female. It would be interesting to understand, for example, why in the Indian case, women doctors are leaving the profession. What is the underlying, causes of this? Is it the fact that male doctors, once they get a female doctor as a wife, decides that they would prefer her in the home? These kinds of things we need to tease out. We need to understand them better. So I just wanted to add my 2 cents worth to Professor Patel's, comments, to say that we need to take it a step further. Gender alone is not going to get us there. We need to kind of explore all of the other kinds of interactions and variables that could maybe help us understand the situation as we're experiencing it today. So thank you.
Thank you so much, ma'am, for such invaluable remarks. Now the floor is open to questions from the audience. You can write your questions in the Q&A box or unmute and speak. I can already see two hands. So Christianas ji, you can go ahead.
Good evening. Thank you so much for such an enlightening session. Particularly the idea of masculinization and feminization of roles was new to me. But as you introduced the concept, sir, I realized that there are various types of interactions happen within these roles based on which gender occupies the masculinizing role or a feminizing role. For example, the interactions are different if it's a male physician and a female nurse versus a female physician and a female nurse. For example, in my practice, I have noticed that male consultants tend to shout at nurses. They'll be like, Sister G, if you did not bring this to me now, then you see what happens. And then they are allowed to get away with that attitude, kind of. And female nurses tend to generally differ a lot when they know that the person occupying the masculinizing role is a male physician, or but they tend to, however, give remarks or push back when it's a female physician and they know that a female physician might be doing something wrong. They feel more confident in pushing back, and this is what I have noticed. Similarly, interactions between female physicians and male nurses are also a little bit different. Like, a female physician does not really order around a male nurse as much as she would do to a female nurse. So I feel that even within the roles, who occupies what position definitely changes the dynamics, and this is just my perspective.
Thanks for all these remarks. I think there is a complexity, yeah. And my experience of 70s was very different than what I see now happening in male-female relationships in the medical professions and between medical profession and nursing. In my time, I remember a woman, getting into the surgery, and a woman who is a surgeon will have to, make a strong impact of being as what I will call firm and decisive as a male surgeon there. It's like, the way we used to talk at the time that, in Indira Gandhi's cabinet, there was only one man, and that was Indira Gandhi, right? So if you want to be in a male's position or male's work, then the woman has to behave more like men than the men themselves will be doing it. I saw it even in obstetric and gynecology, which was dominated by men, at that time. A woman gynecologist had to be more assertive than in order to show that she is as good as a man counterpart there. However, in last 40 years, the things have evolved. There is a lot of evolution there. And since many specialties have opened up to women, women are able to relax in their role, and they are able to bring their sensitivity to the positions that they're occupying. So I really appreciate your point that the interaction between a female doctor and female nurse is of a different kind now than once upon a time it was. Or there may be, I perhaps being strongly dominated by female force, I sometimes wonder that why there are not enough issues related to, say, harassment, and particularly sexual harassment, emerging from medicine in India as compared to they emerging from, say, even educational department, but not from medicine to that extent. But I had seen in my time when I was a student, and then later on when I had some interaction or work in the hospital, I had seen a lot of prejudices, which was the misogynistic prejudices of the doctors there. But somehow or other, that the ethos of medicines were such that the solidarity among doctors was more important than coming out and talking about it. I think that perhaps is breaking down. But yes, as feminization of the workforce takes place, it does bring new sensitivities within the interactions, and that is I think very good positive sign, and hope we'll be able to strengthen it and take it further. Yeah. Lakshita Singh has and Kamlesh Gulia. I think there are two hands there. Who was the first one?
I think Kamlesh Gulia ji raised her hand first.
Please, Kamlesh.
Sir, I wrote the question, aggressive women doctors are still not accepted because it's like, oh, the very demanding and all. But for the men, it is accepted. I mean, the society as at large, how it will change, sir?
I didn't get your question. I didn't get your question properly. You are saying that it is demand of the work and.
Sir, number one, we are so delighted to hear you, and especially this topic, the way you delivered, it was outstanding. It's eye opener for us. What I'm saying that in today's world, in a hospital, when the women are demanding, and I mean, in a way, they're aggressive. Still, they are, they are branded. However, the men, it is taken as a very, very common thing. How to deal with this?
Yeah, it is considered to be man's nature to be aggressive. And it is, as I said, that woman is by nature, that is the ideology, is caring. While the man is by nature is supposed to be aggressive. And you'll find, I have not covered those aspects here, because I thought that subsequent sessions it will be talked about. Is, what are the biases that exist within the medicine and medical textbooks and in the practice of medicine. That is a very big issue, which I had worked on gender sensitization of medical education, but I think you have a separate section there. But it's very, very, very important area where this, characteristic, your norms about men and women getting reflected in branding people, that is one area, but also in the language that we use in describing various diseases, various disease processes, and various behaviors of the patients. You'll find that I remember in early 2000, I think 2005, we put together a critique of medical textbooks written by Indian authors in 6 disciplines. In one discipline, obstetric and gynecology, at the time I was working in Sri Chitra Institute of Medical Science and Technology in Trivandrum. And in the Trivandrum Medical College, there was a gynecologist whom I motivated to write critique of 2 textbooks of obstetric and gynecology. Initially, she was very resistant, saying that I have been teaching this for last 30 years, very senior person. And how can you tell me that these textbooks are biased? I said, but why don't you read it? And she came for gender training that was organized by Mala Ramanathan and Sundari Ravindran and all, along with me. And after that, she went back and reread those 2 textbooks. And then suddenly, one day she turns up in my cabin in the H.U. Menon Center Public Health Division there. And she sits and said that I am writing, but I'm really very disillusioned. I suddenly find that what I was teaching was all anti-woman. I said, how is it textbooks are so against women here? And she was almost in tears that in 30 years I did all this thing. I'm a woman, and I was teaching, telling them that why sperm behaves like this, because sperm is a man, kind of stuff, and what is the role of egg there, and which is written there, in the textbook in that fashion, kind of stuff. Or always believe that women can bear more pain as compared to men, and that's how during labor you don't have to do much for the pain relief. And then again, class perspective, that the laboring women have more tolerance to pain as compared to middle class women. So you do more for, pain relief during labor for the middle class woman, but you don't care about it for the working class woman. These are all things I read in my this textbooks, and I always believed that was true because that is what I always practice, and now I believe that it came from a prejudicial understanding of women. And I think that is where what happens, that's why what we are saying that yes, the labeling and all kind of thing has issues related to gender percolating into the kind of prejudicial beliefs about each other, because we see task as different, a genderized task. We look at men and women and their role in the society and understanding of their behavior in a different manner as compared to the women's one. So yes, I completely agree that we need to pay more attention to it. But I think you have a separate session on it, so I won't encroach on it too much at this moment. Yeah, there are now more.
Yes, sir. Lakshita Singh ji, you can go ahead and ask your question.
Yeah, good evening, professors. Am I audible?
Yes, please go ahead.
Yes, okay. Yeah, sir, wonderful session. I just wanted to ask that in clinical trials in science and research and development and these kind of areas and in the leadership positions as well, like it's mentioned before as well, that the portion of women, the percentage of women is less in this kind of activities. So I just wanted to know that what steps could be taken, plus what steps could be taken in the education kind of education policy so that the position of women can be improved in the particular sector. So just wanted to have some insights on that.
Well, I am a researcher, so what you are talking about women's position in research interests me quite a lot, and there is I think a very good body of literature available, where the work is done to find out what credit and role women have in the research. But before I go into that, let me make one general point that Indian medical education is unfortunately extremely biased towards making you clinician rather than scientists. So they want you to be good clinician and not at all a scientist. This is a major problem that I found. You will, any medical college, I think most of the medical college, maybe one or two exceptions, will not put on the website the dissertation of the master's degree in medicine, of any specialty, simply because they are so badly done. They hardly have any time to actually write good dissertation of research in postgraduate I'm talking about. Undergrad also it is there. And when I was a medical student in 1970s, my professor used to say, well, you have to do a small thesis in preventive and social medicine. I said, yeah, I will do it. No. You go to the department, we have kept five theses there, different one. Each one is about 50, 60 pages. Go and make a copy. Just change the date there and then submit it. We'll accept it. And that's how it should happen, So research is given less importance in general, and that's why we don't make scientists. We make good clinicians. But those who get into science, you'll find, as I agree with you, that the women don't have dominant position. You'll just look at, how many the director generals of ICMR have been women. Soumya Swaminathan was the recent one. But the one who are really pushing the agenda, they are all men. And during COVID time, they're all men. I mean, you say, who were prime ministers, 3 or 4 doctors who actually were instrumental taking in most of the decisions on COVID? Then you'll find 3 or 4 men name coming up. Prime Minister is also man, plus these 3, 4. And even our health minister was also a man at the time. A woman who was there, you had Gagandeep Kang, who was unceremoniously removed, because she had a different viewpoint on COVID vaccine and how to go about it. But this is a thing in that. But At the same time, there's a lot of literature available to show that the main researcher in the papers published by the researchers are normally not women. You know, they are not the first authors to be given. And if you look at the citations, who are receiving more citations of their paper? There's a lot of data available to show that if it is written by man, or the man is the main researcher, the paper will get more citation than if it is done by women. Now you can say that, well, it may be dependent upon the merit of the paper. It is true that in few cases it may be like that. But when you have a trend which is repeating year after year and decade after decade, then you have to think about the systematic problem, you know, that why it is happening like that. That women's contribution in research is undermined, is not recognized as much as the contribution made by others. And I'm talking, I mean, since we are talking about gender, and I'm sorry that I have not used other genders there, only men and women. But if it is coming from the third gender of any kind, you know, LGBTQ kind of stuff, then you will find that they are even much less recognized than even women are recognized. So gender aspects of research that you are talking about is real one, and in my life, if you see my co-authors, you will find that I have co-authored the most with women researchers, and I have found my women colleagues much more intelligent and dedicated to the tasks that I was doing, and I had no problem in having them as my first authors while writing papers, simply because I understood that they were making better contributions. So but that is not happening, unfortunately, and I think it requires a lot of effort and restructuring of our research institution. Perhaps one reason is that they are too bureaucratic, and men are known to love bureaucracy. Then women may disrupt the bureaucracy, and that's how the system does not like women to come there, you know, and keep them below. So we have a lot of structural problem there of the way institutions are organized, and that's how women are not able to come in that position. But there are also prejudices why you don't quote women or cite women's paper, but the men's paper. What else can be done about it? I actually don't have a very concrete idea. But yes, we just bring them out and keep fighting and changing the system. That is what is required.
Yeah, that is very true, sir. Thank you so much. Thank you, sir.
Sir, with the permission of chair, can I say 1 or 2 points, ma'am?
Please, please.
Vibhuti,
Please go ahead.
Yeah, actually, sir, I wanted to just add on. We are fortunate that we have one woman, Indian Council of Scientific Research, ICSR, we have Kala Selvi, who is heading the institute. So that is one good thing. At least in that scientific research, she's heading that. And you are very right, sir. We have a very minuscule budget when it comes to the R&D. So that's why researches are not happening at the scale they should happen. Like 3,500 total crore rupees out of the almost 91,000 crore rupees of the health budget. It is so less R&D budget support. So obviously it is very less. Sir, I just wanted to ask you, share my experiences. Sometime back when I was in Gushaba, West Bengal, wherein I was you spoke about the, having the confidence and women, how they can sort of be there in the labor rooms. I want to share that experience with you. There was one nurse, sir, Gushaba mein, West Bengal mein, when I was monitoring there. So that nurse very strongly told doctor, because medical doctors because they had to do the MD, so they used to stay there for 2 years so that they can get the village experience or something, and that was giving them some additional points for getting into the government MD. So there was one medical officer, उसने उसको कहा तुम बाहर जाओ, बाहर निकलने का, लेबर मैं करेगा, मैं ही इसको लेबर मैं ही 50 किया है, मैं ही करेगा, and that was with such a confidence कि उसने भगाया MBBS डॉक्टर को. And when you were narrating this story, I mean abruptly, like मैं भी हैरान हो गई labor room में, that she was so confident. And then somebody told me, West Bengal and all that Bengali women are very much empowered, that she actually does it like that. Whenever there is a delivery, she does delivery herself and tells doctor, जो भी अब दवाई ववाई देने का तुम लिख लो, अब जो दवाई दे. And that is what I wanted to narrate here. And second thing, once I was in Jaipur, sir. And in Jaipur, we have the nurses. They used to call them brothers. I don't know if you are familiar of that. Some of the hospitals, public health facilities, they are the brothers. But some of your brothers काम नहीं करते थे nursing वाला. That was another thing. Like I always used to see कि ये brothers बैठे हुए हैं, brothers काम भी हैं, but they are not doing that kind of work. These are just a few of the experiences when you
So what
work
you
in.
are saying is that even if a man becomes a nurse in India, the man is reluctant to do the nursing work. They would like to be recognized more as doctor. I mean, I can tell you, like say at the primary health center level, you have in Maharashtra, you have a male health workers and you have a ANMs as female health workers. Okay. When you go to the village and you ask about the ANM, they say, oh, nurse by, yeah. That is a nurse by, And then you ask about the male health workers, oh, doctor hai udhar, And a man who is doing this even much less paramedical work than an ANM is doing, because ANM is doing all the work of the male worker, plus she is doing, maternal and child health also, which male worker is not doing, right? So she is doing double work, and yet she will be called nurse by, while the male worker will be called doctor in that village. That I saw when I started I did a lot of social science research. So, that's how I learned that people's image is like this. And that way, that male worker will be reluctant to do the job of the woman, the nurse, because it's a feminine job, it challenges your masculinity because you have to behave very differently with the patient. So yes, becoming a brother is not sufficient. You have to become a nurse. That is what is more important. Yeah.
Thank you, sir.
I think there's one more question, sir, from Jyoti Rubeji. Kindly go ahead and ask your question.
Please. Yeah, we don't want to miss out anybody.
Hi, thank you very much, sir. Am I audible?
Yes, please.
Okay. Thank you very much, sir, for taking my question. Sir, I would like to ask my question with my own example. Actually, during my pregnancy, I had some issues. So I went to my gyna and then she said she need to consult with her senior. And she asked me, my senior is a male gyna. Would you like to show it to him? So I point blankly refused because I never wanted to show my body to a male gyna. So that time, I thought it has got to do with my upbringing and the kind of the ideology has been given by my parents to me not to show your body to a male person, which changed over the period of time. So I was wondering, what is the status of male gynas in India? Do we have? I'm sure we may be having, but then do we have? What is the number and how comfortable now women are showing their body or showing them to male gynas?
Well, I think I don't know. Is there any there is enough literature existing in India? Unfortunate part in India is that the discipline of what we call medical sociology is very underdeveloped as compared to, say, USA. The USA in 1950s and 60s, you find a massive proliferation of sociology of medicine. While in India, sociology of medicine has remained very truncated. Anthropological theology and medicine has also remained very truncated. Only in recent times, in last 20 years, I see the upsurge coming. And a lot of work is being carried out. And when we started doing health service research and from the social science perspective, we were very few of us who were involved, and some other people were from JNU, the pioneering department of community medicine there. So it was a very, very problem. That's how we may have very impressionistic accounts, but we don't have very good studies on that. That how are women comfortable going to the male gynecologist? They were not, definitely. In what happens in late 1970s and 80s, there was a massive upsurge of women's movement in India. The women against rape, women against oppression of women in this country, the women against dowry. You find all the laws which has changed in India related to women. They're taking place in early 80s and mid 80s, simply because of the strength of the women's movement. The law related to sexual assault and rape. The Mathura rape case became very prominent in 1978, 79, and led to massive upheaval. So that also brought along with it a lot of critique of medicine. I remember as a member of, say, health activist group, Medico Friends Circle, when we met in Anand, I think Vibhuti was also there, Anand meeting in 1982 or 83, where we were looking at what are the biases in medicine against women, and one of the topic we were discussing that is medicine inherently sexist. Okay. And we found that when women came, large number of women activists came in that meeting along with the doctors. And they started critiquing the medicine, saying that they don't take us seriously. And all the men who were sitting there as a doctor, they will keep asking, but give us data, research data to prove that you are being, they are being biased against you. These are anecdotal information, kind of stuff. Yes, they were anecdotal, but they were experiences. And they should have made all of us to introspect. So at that time, there was a lot of clash between the medical perspective and feminist perspective. And that led to one near breakdown of the meeting, and women had a separate discussion and all. But it learned from it. This organization learns from it. And today, MFC is one of the highly gender-sensitive organization that you have in the country, which is of the health activists. But it also at the time brought about this whole idea that women will have to take care of themselves. They cannot rely on the man. And the books like Our Bodies, Ourselves, that was written in 1970s by the international developed country feminists, became so popular, and Indian editions went all around, and its translation went all around, saying that because medicine is so inherently sexist, and the medicine is dominated by men, and most of the gynecologists, as I said, that when I was studying medicine in 70s, 70 to 80% of gynecologists were doctors. I said, they don't listen to us. They don't understand us. If I have a dysmenorrhea, they say, get married, rather than, telling me what to do about it. So they started moving away from male gynecologists, and that created a demand for the female gynecology. And you'll find that more and more women started going into the obstetric and gynecology. Today, the ratio is inverse. More than 70% of the gynecologists are women. And you can say that they have become a little more sensitive and brought their sensitivity. But at the same time, you'll find that some of their way of doing medicine also reflect the traditional way of masculine way of doing gynecology. So that is a different issue. I can elaborate on it quite a lot, and I looked at it a little more closely. Dr. Bakshi was talking about the nurse asking doctor to go outside and do it, but there are also things about labor room in the public hospital which are very abusive to the women who undergo labor, and I have seen it with my eye, where even nurses are so abusive about the women, whose labor they are conducting. So even if they say that male doctor should not be there, but she will tell woman, the way she will treat woman who is in labor is very, very different. When you take pain, but while asking her to do it, they are not as gentle as they would be. But the same nurse or doctors, if he's working in the private sector, will be gentler with that woman than in the public sector. And there is a lot of abuse of women in the labor ward, and I think that is another area which is a very big one, and where you will find the gender distinction is not connected to the sex of the doctor or the nurse, but it is the behavior that brings about their role, which is connected to the role as it is defined by the larger system, which is a patriarchal health system. And unless they understand it differently, they are not able to change the behavior. And some of them have started doing it because of the lot of pressure coming from below, and women speaking out against abuses, lot of campaign going on against the abuses, and that making them more sensitive to treat them differently. So, these are all simultaneous movements which are there. So yes, I can only tell you that it was the women's pressure that changed the gender composition of obstetric and gynecology. And it is also women's pressure. If they continue to exert it, it will humanize the obstetric more in coming time. It will also change the behavior of doctors as well as nurses towards women who are in labor, and that way gradually improve. But remember one part, and I come from medical ethics, and being conscious about ethics by definition is being conscious about the patient. The ethics and rights are very closely linked. So if a woman who comes to you has certain rights as a woman and you recognize it, then they become your ethics. So if you violate your ethics, you are also violating the rights of the woman. These two are very closely connected. Doctors were not born with the idea that informed consent of the person should be taken, who is a patient. They actually learned in the course of time. Why they learned it? Because people whose consent they had not taken properly or taken blanket consent, they talked back. They fought against them. They filed cases against them. They harassed them. And sometimes they beat them up, right? And so we learned that, yes, we have to respect the patient. So respect comes from the assertion of the patient, that you remember. If you want to change the medical system, those who are using the medical system will have to take care. But if outside system is highly patriarchal and we have not questioned it, then you are less likely to go into the medical system and question the patriarchy of the medicine. So you'll have to, that's what Jaya was saying, that you have to question the patriarchy in the society in order to be very conscious about how to question the patriarchy in the medicine. So these are very closely connected, both of them. And more pressure coming from the patient will make doctors more ethical. Whether doctor is man or woman doesn't matter. How they should be behaving with a different kind of patient and looking at their special needs, how they should be actually providing services and care are very, very important issue. And that will change, the patriarchal nature of the medical system in general, and make it more sensitive to all the genders which are going to the medicine for the care. So it's a long way to go. It's not going to be that easy. But I will say that medicine will change if people make it to change. Otherwise, it is very, very happy with the way it is. And so far, whatever change has come about is not because of any divine revelation they got overnight. It has come because of the people made them to rethink about their role.
Thank you so much, sir.
Yeah, it is quite late. Yeah, it's almost 9 o'clock. Yeah, I have a tendency to start talking and then not stop. I'm sorry about that. Anyway, yeah, I think we should end here. Thank you very much.
Thank you so much, sir, for such an informative session. We look forward to having you at the IMPRI Web Policy Talk in the future. Now we shall move on to the participants' introduction. So for the participants' introduction, you can switch on your video by accepting to join as a panelist. Please briefly introduce yourself, including your name, location, organization, the reason why you chose this Monsoon school, and any other things that you want to highlight. So I think we can go ahead alphabetically. So please accept the request of joining in as a panelist and we can start taking in the introductions. We can start with Ananya Verma ji. If you are here, please go ahead with your introduction.
Yeah, hi. So I'm Ananya. I completed my master's in gender studies last year. And since then, I've been looking for opportunities to work in the women and gender sphere. My fields of interest are mainly working with the sex work community and working in the female sexual and reproductive health. I found out about this school program through Instagram, and I obviously wanted to. I've been feeling a sort of gap between myself and academia recently because I stopped studying after my master's, and I've been freelancing with a few NGOs right now. So yeah, I just thought this would have been a good way to get back to academia maybe. And I thoroughly enjoyed both the sessions today, and I'm looking forward to learning a lot from the next sessions that we're going to attend. Thank you.
Thank you so much. We can move on to Alisha Bijiwala ji for her introduction.
Sure. Hi, everybody. I hope you can see me. So my name is Alisha. I'm based in Mumbai. I'm currently working with an organization called ARPAN, who are working on the issue of child sexual abuse. So while I'm sort of learning more and more about CSA and about, that issue, I think there is a bit of time with, sexual reproductive health, with gender equity, with so many things. So a lot of new learning for me in this session, a lot of things I'll have to go back and maybe study some more about, but I'm very, very glad to be a part. Thanks.
Thank you so much. We can move on to Bhavya Singh ji. If you're here, please give your introduction.
Good evening, everyone. I would like to mention that it was a very informative session. And when we were teaching the masculinization, and there were 10 boys in our class and 70 girls. By the way, I am pursuing the basic psychology honors, so that's why. So I'm from the Uttar Pradesh, but I'm currently staying in Bangalore for the studies. And I have been looking forward to this session because when I was doing the internship, so I always liked this fact that while we only study the ethics, like I was working as a supervisor, so they were like, you should know the psychology ethics or psychiatric ethics, but they never told about the like the execution, the implementation, the strictness, and also it I also like the fact that when you're working as a doctor or as a nurse or as a psychiatrist or as a psychologist, we are aware of the ethics, but I think it is very important to spread the awareness to the patients or to the people. No, even not with like all ethics present, but at least the basic rights. For example, earlier women didn't know about the information that when the male doctors they're operating on the woman, so female nurse has to be available. So I think rather than the profession, we also have to raise awareness to the people. So that's why I think this is one of the way to get information to study about the gender equality. Thank you so much.
Thank you so much. We can take the introduction of Jyoti Dubey ji. Kindly give your introduction. Jyoti Dubey ji, if you're here, kindly give your introduction. We'll be glad to hear about you.
Hello, can we move to Bolam Maji?
Good evening, everybody. I'm Bolima. I'm based in Gurgaon, though I'm from the South. I work as a journalist and an educator. I've been in the profession for almost 2 decades now. From college, I've moved to school because here I feel I can make more of an impact. And I look forward to hearing from the panelists and have had a very interactive session today. Thank you.
Thank
What is
you
your
so much.
discipline?
Ma'am, you can go ahead. Whatever you
Yeah.
were saying, you can ask.
No, I just was asking what is her discipline. That's okay. Later on, she can write in chat.
I'm sorry. Yeah, I just, yeah, okay, fine. I specialize in sociology. I finished from JNU and I've worked with Professor Oman, T.K. Oman. So I
Right.
specialize in gender studies as well.
You're
Thank
familiar
you.
with this.
Thank you so much. We can move on to Bhavi Palrecha. If you're here, kindly give your introduction.
Hi, my name is Bhavi Palrecha. I have just recently graduated from my engineering course. I've done biotechnology, but I also see there's a lot of gap in the actual science and the policy and the kind of systems that are in place. I do think there is scope for improvement, and I'm trying to figure out a career in policy making, and that's why I am here. And I just wanted to stand on the shoulders of giants such as the panelists who, and the people who spoke today to get a better understanding of.
Thank you so much for your introduction. We can move on to Shalini Mallikji. Kindly give your introduction.
Hi.
I think she's writing in the chat box.
Yeah, she's written some issue with mic.
Okay, no worries. You can give your introduction in the chat box if that suits you. We can move on to Shama Rao ji for her introduction.
Hi everyone. Can you hear me?
Yes.
Okay. My name is Shama Yura. I'm actually currently doing my MSc Research Ethics program from Center for Ethics, Yenepoya deemed to be university. So I joined this because I wanted to know more about the role of women in research, and mostly with the participation related as participants in a study. If there is any difference, what is the difficulties they face and all this. Thank you.
Thank you so much for your introduction. We can move on to Sumit Dahipale ji.
Hello, am I audible?
Yes.
Hello everyone. Myself Sumit Daipai. I'm pursuing currently international journalism. I am in last year, so my subject is gender journalism. That's why I attend this program to know more about gender journalism and related to that subject. Thank you.
Thank you so much. Also, Shalini ji has given an introduction in the chat box already.
Yeah, she's a
That's
doctor
it.
and writer. Yeah.
So we can move on to Vandana Raghunath ji for her introduction.
Yeah.
Good evening, everybody. Good evening, madam. Good evening, sir. So I hope you remember me. I was in a PGDME course when I met you, ma'am. And so after finishing PGDBME, I'm in the ethics this thing in our college. I'm member secretary working there, and also I'm a chairperson for the SHE committee. And I'm actually a professor and head of the Department of Oral Pathology. But after pursuing ethics, I started, getting interested more into learning about all this gender-based this thing. And I never leave any opportunity unturned if I have to listen to you all because it's like, the more knowledge I get, I can share that knowledge with all, like, and I can, that is the main intention. Like, I'm sorry, I'm not in any gender-based, what do you call, profession or a writer or anything, ma'am. So that part you kindly excuse me, like, but it's the out of interest. I just want to participate and learn more, ma'am. Sir, sorry, sir, if I'm not into, that particular gender-based anything, like, but I want to learn, I want to know. That's all. Thank
Which
you.
college, Miss? What do you teach?
With Narayana Dental College, ma'am.
You're in
Veena Vaswani ma'am had sent the mail this time. Usually I attend all the IMPRI courses, but this time madam sent the invitation telling that Center for Ethics you can join
So
from
you are a
Center.
dental professor. No?
Ah, yes, ma'am.
Dental.
Oral pathology, dental college.
Okay.
Thanks a lot.
Understood. Yeah.
Thank you so much. We can move on to Prabhav Nitiji, our last participant, for the introduction. Prabhav Nitiji, kindly give your introduction if you're here.
Prabhav Nitiji. Can we move ahead?
Yeah, we can wrap, Samprikta.
Yeah, okay.
Vibhuti ma'am, your closing remarks, you want to?
I think Jyoti Dubey has come back,
Jyoti?
so you can ask her to introduce.
Jyoti ji, please go ahead. Yes.
You are muted.
Oh, sorry. Am I audible now?
Yeah. Now you're audible. Yes.
Okay. Hi, my name is Jyoti Dubey. I work for one of the embassies. Frankly, gender is not my forte. My forte is finance. But recently, I shifted to a department where we deal with a lot of NGOs, and especially largely we work on women. So based on that, it created my interest to learn about women and women equality, gender equality. So because of that, I'm here.
Thank you so much. Now I would like to invite Professor Vibhuti Patel ji for her closing remarks.
Yeah.
Over to
We
you.
would have also liked the co-organizer of this course, the Professor Veena Vaswani ji. I saw her name earlier, and we thought that she would be speaking, but I think tomorrow we will start with her. And I would like to, today we had a very, very interesting session. It was an electrifying, intellectually charged environment where all the participants got galvanized into getting into the discourse. We thank Dr. Jaya Velanker for making a convincing case in favor of engineering healthcare as a win-win formula for the individual, family, community, society, and nation states. And Dr. Jesani for deconstructing the patriarchal model of healthcare system operating on a bureaucratic top-down model of delivery of services and its limitations, and also suggesting an alternative of democratic, participatory, people-oriented bottom-up approach in health policy structures and systems. Over the last 40 years, we have ourselves witnessed how the changes have come. We remember when we started Forum Against Sex Determination and Sex Pre-Selection, the medical fraternity called us lunatic. We were humiliated, we were thrown out of the meetings of Foxy. But in course of time, our workshops and articles that we wrote and the public debate we had and the panel discussions we organized made so many of them understand and be humble about the whole social processes, which are so complex. So you just can't stick to your medical understanding, but you have to see the political economy, see the connections, what are the gender stereotypes, and they also percolate into your thinking. So I think that we have seen, even when it comes to the whole reproductive right issue, earlier they were talking only about reproductive control. It took me nearly 30 years of continuous effort by the women's movement, through our experiences, through case studies, through public debates. The paradigm shift took place from reproductive control to reproductive rights. So I think gender relations, they change when they are questioned. So it is very important, and knowledge is a key to questioning any of the hegemonic thinking or hegemonic ideologies that we have. In conclusion, I would like to submit that both government organizations and non-government organizations, state and non-state actors, will have to converge, and we need to do better together to support and enable gender equality so that everyone can enjoy health for all. WHO has been continuously hammering that health rights are human rights. Today's session took us on a powerful expedition from understanding the barriers that we are facing because of the gender stereotypes and the patriarchal biases in the system, structures, and policies. And also, we all shared so many of our personal experiences, and that also gave us a strength for the inspiring possibilities for future. Thank you very much. Over to IMPRI.
Thank you so much, ma'am, for such an insightful remark. Now, I would like to propose the formal vote of thanks for the day. As we come to the end of the first day of Healthcare and Gender Equity Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges, an online international monsoon school program, a 4-day immersive online certificate training course organized by IMPRI. I, Samprikta Banerjee, researcher at IMPRI, Impact in Policy Research Institute, would like to propose a formal vote of thanks on behalf of the IMPRI Gender Impact Studies Center, GISC. We are grateful to our experts for the day 1 sessions, Ms. Velanker and Dr. Amar Jesani for taking out their valuable time and for their thought-provoking insights on the topics. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for the session have been shared in your email, and a video of the session will also be shared with you for learning. We are really grateful if you are watching us later on YouTube or listening to us on our various podcasts or reading our publications. The feedback form will be shared after the entire course is over. Kindly fill it in for the certificates to be sent to you. We hope you continue to join in the future to our IMPRI Web Policy Talk and Web Policy Learning. With this, we come to the end of the first day of this course. Wishing you a good evening. Thank you so much.